Yes, sir. Taking it live now.
What is the time?
501.
151 people came. Very nice.
Yes, very nice.
Okay, let's start.
You can start, sir.
Yeah. Good afternoon, everyone, and I welcome once again everybody to General Practitioner Association. It's been a long time that we have not been met due to COVID reason and other reasons. So today we have our own doctor, Dr. Pushkar Shirkhane, who everybody knows he had visited our Goa about 2 to 3 years back. And he's once again to guide us on a very, very important topic, which we are eager to listen to him. I would request we will just have a minute silence for the doctors and the members who we have lost during COVID. So I request everybody to keep a silence for 1 minute. Thank you. Dr. Pushkar, I welcome you today to
Thank you very
General
much.
Practitioners Association. We remember you very much. You had a wonderful talk. We had enjoyed your talk. And our members themselves, they had suggested that we should request Dr. Pushkar to talk on this topic. Dr. Pushkar is going to talk on a topic which is very sensitive and very important for us. How to treat a patient in our general practice, our own practice, where a small clinic, a hospitals is different story. When a patient comes to a small clinic where we have very limited resources, sometimes we don't have an antigen to do, we don't have blood test to do, and patients are not willing for testing. There are many things which Dr. Pushkar will guide us, and after that we will be taking question and answers. I request each and every members, if you have any doubts, there is a chat, there's a panel downwards, there's a more, you press that more button, then you go to chat and write your questions. So in between our lecture, Dr. Pushkar will read the question and he will try to answer. Yes, doctor?
Yeah, that's fine. Will you be able to see the chat also? Or
I will also see the chat, and in between I will interrupt you, sir.
That will be fine.
That will be better, so that you will be in a flow, and
I will be in a flow, and it will be nice interactive session. In fact, it is always nice to be all together and sort of talking to each other. But because
Yes,
of
sir.
COVID, we are kind of forced to do these kind of webinars. But it
Yes,
is
sir.
wonderful. In fact, we can reach to a bigger audience also. There are, as you also must have realized, the COVID, there is a dark side of COVID, and
Yes,
there is a
sir.
bright side of COVID also.
Yes, sir. Yes, sir.
There is
Uh,
something-
I'd like to invite Mr. Piyush, who is taking care of the audio, video, and everything from DG Shield. We thank DG Shield to support us in this webinar. Now, I request our secretary, Dr. Paresh Kamath, to introduce Dr. Pushkar, and then we'll go ahead with the lecture.
Can you hear me? Right?
Yes.
Yeah.
Yes.
Good evening to you all. Good evening to all the members present as well as other doctors and invitees. I am Dr. Paresh Kamath, the GPA Goa Secretary, and I'm here to introduce our speaker, Dr. Pushkar Shikhar Khane. He did his graduation and post-graduation from St. GS Medical College and KEM Hospital, Mumbai, Maharashtra. He did his MD Medicine and DNB Medicine. He is affiliated to the following hospitals in Mumbai. They are Shushrusha Hospital, Dadar, Wadia Maternity Hospital, Parel, Raheja Hospital, Mahim. His areas of special interest are infectious diseases, sleep medicine and its relation with metabolic disorders, and obstetric medicine. His hobby is singing. With this small introduction, I present to you all today's speaker, Dr. Pushkar Shikhar Khane, who will be enlightening us on the topic how to treat COVID patients in general practice in less resources and the third wave. Oh, thank you, Doctor. Over to Dr. Pushkar.
Thank you very much. And it indeed gives me I'm really getting goosebumps. Feeling so nice to be with you all. And when Dr. Samuel introduced me at the outset that Dr. Pushkar is our own doctor. So I was so thrilled to hear that Apulki, that attachment he expressed. We have actually speaking, I only visited for the talk once there, but with that one meeting also, and that one talk that I had held on fever as a whole. That time we had covered fever as a whole, but we developed such nice bonding that we have also been in touch thereafter. So I'm really happy and pleased to get this opportunity and to get this invitation to talk about this topic of COVID, which has been bothering us for last almost 1.5 years, and it's a really a challenge that the whole globe is facing. In fact, the whole of this earth is facing this problem, and it's something which is very unique. In fact, as a student, we had probably just studied what pandemics mean, and it was just sort of brushed up in that curriculum, but we had never anticipated that in our lifetime that we will be actually facing such a pandemic, which will bring the whole world to a standstill, which will also create so many other problems like medical problem we know, but the social problems, economic problems, and it has completely changed the scenario in which we are living in just now. Like the way we are now interacting with each other is always everything from distance. That we are fortunate to have this technology which has evolved over last some years, and we are using the technology to the best advantage. That's a good thing, that this technology which was available to us, which we can apply and then continue our lives. Like it didn't happen that our lives kind of completely came to a standstill. We found via media, and through the via media, we are able to now, in fact, continue our life in a slightly different way, in a modified form, I would say. But the modified form also, we are able to push ahead. So as doctors, I know that for last almost 1.5 years, you must have been reading, you must have been talking, you must have been listening to so many webinars, and you are aware of so many developments which have occurred because of COVID. But what different or what new can we talk today? That was the question which came to my mind when Dr. Samuel invited me to talk about this topic. I said, almost for the last 1.5 years, we have been dealing with this topic. And बोलते हैं ना, आज की story का जो climax है, I feel I should just crack the climax at the beginning, and then we will see the movie in little flashback type of manner. Because all of you must be very keen, and I was told right at the beginning, almost 150 plus viewers are there, and I'm very happy that so many persons on a Sunday evening, that too today being a Raksha Bandhan day, have shown interest and joined this webinar.
Sir, we have 264 participants.
Oh wow! The number has really shot up.
So they all, yes, sir, they're all listening to you, sir.
Thank you so much. Thank you so much. I'm very happy. So at the outset, I thought, let me tell the climax of the story and then go in the flashback, because some of the attending persons may be also because we have almost 2 hours time. So I'm happy that you gave me a good, decent time to talk on this topic. So it's not that I have to be in a hurry or rush to finish off the topic. But वो story के end तक पहुंचते पहुंचते some people may sort of have some other commitment. They may want to leave also at one point. So let me tell this climax. Every story has a good news, bad news. Like पहले एक joke हुआ करता था that एक doctor went into the ICU and then he came out with a very grim face or right a mixed reaction face, and he told the relatives that I have two different news to share. One is a good news, other is a bad news. So which one would you like to hear first? So they said, obviously we'd like to listen to the good news. So he said, no, yeah, your patient's fever has finally gone. Now the fever is under control. So that was, and the sad part, though it is a little grim way to put it, but he said, what is the bad news? The patient is no more. So every doctor also has this kind of good news, bad news to share. So about COVID, let me first tell you let me tell you the bad news first. Let me do the other way around. So the bad news about COVID is that at the end of 1.5 years, in spite of our human race has been so scientifically now developed, and we are now sending our missions to Mars and so many other long distance things. In spite of the scientific development, at the end of 1.5 years also, there is no good treatment for this disease. So whatever development in the field of science that we have achieved, this particular minuscule microscopic, I wouldn't even use the word microscopic, electron microscopic entity on this earth, which is not even a living being. It is a non-living being which becomes living when it is inside a living cell, that is a virus. Such a virus, we have not been able to find a solution to that. We have been really brought on our knees, and we have been really been taken to task. I would say that all kinds of difficulties we have faced just because of this minuscule creature, and we have not been able to yet find a definite solution for this problem. So which is definitely a bad news, because each one of us, I'm sure, must be keen to hear from somebody who is read a little more, or somebody has got a little more experience. That आज तो ये डॉक्टर आके कुछ हमें बताएगा, कुछ भी, there is some wonder drug which has come, which will sort of control this illness, and we will be able to be free from our forced COVID appropriate behavior that we are always compelled to follow, that is wearing the mask and keeping distance and not having parties and not being able to enjoy our lives. So कोई तो ऐसी एक remedy अभी तक तो मिली होगी कि by which we will be able to sort of get rid of all this nonsense that has been going on, and there will be some wonder drug. But unfortunately, even as it stands today, there is no wonder drug which has come, which can be just, you take a course of 5 days and just finish off the disease. That has not happened. So that is definitely the bad news. But the good news is that we are definitely seeing a significant decline in the number of cases. The second wave, which thrashed the whole of India, especially as we see, and as I know, the state of Goa also suffered badly during that phase. Like when the first phase was going on, when everything started in city of Mumbai, we used to continuously follow the numbers, and we used to see, अरे गोवा के number तो बढ़ते नहीं, तो 6 पे अटके हुए. So we were sort of kind of a little jealous from here. क्या कर रहे हैं गोवा वाले लोग, कितना they have been able to control the disease so well. Unfortunately, it did not last too long, because somewhere that lockdown, which was initially imposed very quickly by our government, and gradually we started seeing a significant decline in the cases, and slowly the lockdown was kind of opened up. And as the lockdown was opened up, everybody sort of assumed that India has been able to conquer this disease of COVID. We have got some kind of immunity in us. We have been sort of not following the health norms very well. We have been following some practices which are not so clean, and because of which maybe we have got some inbuilt immunity, or we have been taking TB, that is our BCG vaccine, that is giving some protection. So because of some unknown, or ours is the land of gods, and that is why we are kind of protected. So we were in that in that phase where we assume that COVID has sort of gone away from India, and then the carelessness began, and then people started traveling around India, especially Goa being such a nice state and such nice beaches and very lively atmosphere there. I'm sure you must have started getting visitors around that time of after October 2020, and then November came, the December came, and slowly, as we started seeing in the month of January also. In fact, my daughter who is studying MBBS, she underwent her second MBBS exam in Mumbai in month of January, which was held in person. She went to the classroom and she wrote the new papers there in the classroom. Her practical exam was conducted in the month of January, and we were almost sort of hoping that we are kind of got rid of this COVID. But then it was not to happen that way. The unfortunate part that happened was that this carelessness or whatever, that intermingling which happened everywhere, the use of masks also kind of went down. And from the month of February, we started seeing that the cases started gradually increasing. You all must have studied in the colleges, the physics. In physics, there is a nice curve that we talk of. There is called an exponential curve. The exponential curve is a curve where it initially remains very flat, and then it just surges up. It's like you multiply 2 and you just keep going ahead. 2 into 2, 4, 4 into 2 will be 8, 8 into 16. So initial numbers are very slow, but as it goes further, then it goes 256, then it goes beyond a 512, then 1024 and 2048, and then it just picks up. So something on those lines happened, and the third wave just tanked. And I'm sure you all have gone through a very tough time that time in Goa also, because that's why this topic is still so much in your mind, because though we have, after the second lockdown, which was imposed in Maharashtra, it was imposed in month of April. I'm sure around the same time your government also must have done the same. And then now June onwards, or rather July onwards, we have been seeing a significant decline in the number of cases. But that decline now has reached to a phase where we have almost plateaued out, and we are seeing a fixed number of cases. Like right now, Mumbai, I would say we are seeing around 200 to 300 new cases every day. But whether this is going to continue for long or no, that is the question in my mind. And that is where I want to give you the bad news still continues, that we are yet to come to the good news part of it. But the bad news still continues, that the fear or the threat or COVID is still lurking on our heads. So it is not that we are now with the second lockdown, though the numbers have come down, we are kind of through with the cases. And this has been shown with other countries also. Like even Europe has experienced a third wave, and even in Australia and New Zealand, which were almost like no COVID countries, have also started seeing cases. China, with their very strict control, which the iron hand that the government can follow there because of their kind of dictatorship that they have, they could control the disease very well. I mean, I really feel that we all should be copying their model, what they did in controlling the disease. But there also some new cases started developing. So when the human behavior is, especially as we have learned from our childhood, that man is a social animal. This is the phrase that we have heard in our very young school days. So man, being a social animal, cannot remain at one place, and it does not like to remain isolated. A man always likes to mix. Man always likes to have gathering. Man always likes to have parties. Man always likes to have meetings. So some or the other way, we want to have marriage functions, birthday parties going on, or some music programs going on, or we have dramas which we like to watch. We want to watch cinemas in a cinema hall. But all that is our nature, that we want to explore, we want to travel, we want to go to different places, we want to stay in hotel, we want to eat food in restaurants. But all this is, in spite of being our basic nature, is something which is completely going against the way in which this COVID virus is transmitting. So the bad news is still that we have to continue our COVID appropriate behavior. If we do not follow our COVID appropriate behavior, we are again going to go back to the same situation. So this is the warning bell or the initial message that I want to give to all the attendants that who are here with us, that whatever we will be planning now, henceforth, I mean, we will be discussing how to manage our cases in the resource limited setup, or even in hospitalized patient, what we can be doing. But still, as there is no definite remedy for this disease, the only sure shot remedy that remains is the COVID appropriate behavior. Now, the question in your mind will be that what about vaccination then? Why are we talking about vaccination?
So can I take one question of the member?
Please.
Yeah,
take.
the first question is, sir, ivermectin is in early phase. Is it underused also in post-COVID, as studies in Europe revealed, also for HCQ?
Wonderful. In fact, I was expecting this as the question from Goa, because when Goa announced the ivermectin prophylaxis, I was one of the doctors who actually even suggested in whatever the social media or some post that why not Maharashtra is following the footsteps of Goa. Because ivermectin is one drug which has been studied a lot all over the world. It is actually not a new drug which has come for COVID itself. It is, as you all know, it's a deworming drug. It has been there in the market for almost last 40 to 50 years. So it's a well-studied drug. It's a all approved drug, FDA approved drug. Only what we are doing is it's a repurposed drug for COVID. Unfortunately, the studies which have gone on till now, as far as ivermectin is concerned, have not yet reached to a very conclusive message that it is working for sure for 100%. So that is why the confusion goes on. But in my personal experience and the group which has been working on this, they have shown that those countries where ivermectin has been used as a therapy as well as prophylaxis, there has been some real interesting, good success stories seen. So I am of the opinion that we should continue use of ivermectin till the time it is finally rejected or finally accepted. Rather than not accepting this drug, it is better that we use, because in resource limited setting, I was going to come to that good news what I was mentioning about. The good news is the monoclonal antibodies which have come in the market. When I started my talk, एक good news देनी बाद में आप bad के बाद good दूंगा. So good news is that we have got monoclonal antibodies in the market, but that also comes with a big bad news that this monoclonal antibody is costing a bomb. If you have to use monoclonal antibody, the cost of this medicine is 1,20,000 rupees. 1,20,000 rupees is the price of that monoclonal antibody, and that is the dose. If we have to save some money, what we are doing is we are giving only half of that, and half of the medicine dose is saved back with the patient only. Like for example, patient comes to the hospital, and if you have to use monoclonal antibody as a treatment, so we open the vials, and the vials opened will cost 1,20,000 rupees. So he has to pay that much from his or her pocket. Thereafter, only half of that dose is given to the patient. The remaining half is given back to the patient to be kept in the fridge for next 36 hours. Now, if within those 36 hours, if we find another patient who is needing the medicine, the company's medical representatives call this patient and tell them that now your remaining dose you can get back, and that can be used for the second patient, and then he may be able to recover 60,000 from that. So that is how the cost can be brought down to 60,000. But still, the cost of 60,000, how many patients will be able to afford? That is a big question. So if internationally speaking, and if we have to go by the evidence-based data, the evidence-based data right now is supporting only use of monoclonal antibodies and no other medicine. This all that I am sharing with you is the reference to this. I want you to all note down. I would in fact ask you to keep some notepads also with you. I have purposely not made slides for today's talk because I want to keep it as a heart-to-heart discussion and a nice lively interactive session. That's why I did not make slides, because then we start only seeing slides and the faces get vanished. But if you can keep a notepad with you, what I'm going to share with you just now is something worth noting. There is a site called as uptodate.com. Yeah, I will repeat. There's a site called as uptodate.com. Now, this uptodate.com is a like a ongoing textbook. It's a textbook which is continuously undergoing revision. So to talk to you today, I again went back to uptodate.com over last 2 days, and I went through the COVID literature just to keep abreast with the absolute latest what is happening today, because that material is continuously updated material. So if I have to tell you that whatever I'm speaking right now, whatever I'm sharing with you is on the basis of uptodate.com, and apart from that, my personal experience and everything that gets added to it. But the theoretical knowledge that I'm sharing with you is on the basis of that. Now, if I have to quote uptodate.com and again reiterate my point, and the therapy options which have been discussed as far as COVID is concerned, the current literature has removed hydroxychloroquine. They said hydroxychloroquine is not active, is not acting. The literature also has removed azithromycin from the list. The literature also has removed doxycycline from the list. The literature is not talking about favipiravir at all. That is the drug which we have all used so much in last, especially the second wave, and we used in the first wave also, which has been going, which was in Mumbai. So these drugs are not featuring as the therapeutic options in the latest as it stands today. That is again, I would say a bad news. That's why I started with my first thing, that the whole thing is finally it has come to a stage where we have almost no therapy options available as far as the treatment of COVID is concerned. But then what is available, that is what we will discuss. So as far as ivermectin is concerned, I'll come back to that question which our doctor friend has asked, that ivermectin is still, if I read the exact line in the uptodate.com's message or their text, it says that it is still under evaluation. So uptodate.com still say that ivermectin is not completely removed out of the therapeutic purview, but it is not something which has still been accepted also. So it is somewhere in between.
Sir, excuse me. Sir, if you if you say that you should take ivermectin as a prophylaxis, then what dose will you recommend?
Yeah,
members would like to know that.
Yes. So that's a very good question. I am myself taking ivermectin as a prophylaxis for last many months. In fact, it had all started with hydroxychloroquine, and as our ICMR had recommended hydroxychloroquine, I took hydroxychloroquine almost for 3, 4, 5 months, and thereafter, in fact, when the ivermectin became more popular, I myself changed over to that. So currently, the dosage regimen recommended is slightly variable, but if you have to make it more precise and easy, I would say that at least take it once in 15 days, 12 milligram tablet. Once in 15 days. If you can take once in a week also, it is fine. And if not anything, ivermectin being a deworming drug, it will definitely keep you away from the worms at least. So, in fact, I am of the opinion that if any government, in fact, takes it as a therapy option, and if somebody challenging, like I was just discussing with Dr. Samuel also, that why government of Goa stopped giving ivermectin. And so I was told that there was some court case which was filed and some kind of petition filed against government, and that finally led to the withdrawal of ivermectin prophylaxis in Goa.
Sir, in this second wave, suddenly we saw that young patients were getting admitted and they came with viral pneumonias. And that time the government took a decision that we should give ivermectin to the youngsters at home. Then somebody filed a petition, and then there was a stop.
But what was the effect of that? As a doctor, I would ask you, like when this kind of a decision was taken by the government on the field, what did you experience? Like what was happening to your patients? Were they kind of improving, or what was?
So that improvement we did not see because that was not implemented. but the patients, youngsters who were coming, they were all neglected. They came late to the hospital. That we knew that all young people who was coming with viral pneumonia, they were coming to the hospital very late.
Correct. So that was very unfortunately. See, the way the second wave happened, it was very unfortunate, and we really lost young people. Even starting from 20 years above, also people really lost their lives in the second wave. So that was really sad. And there are and though they are still called as anecdotal studies, I would say, because our evidence-based medicine has sometimes, I feel, has paralyzed us to such an extent that we want to ask proof of everything. मराठीमध्ये एक म्हण आहे, बाप दाखव नाही तर श्राद्ध कर. That you show your father where, otherwise if you are not able to show the father, you have to do the last, whatever your last rites are there. So that kind of attitude we have developed in the field of medicine to an extent where we are not willing to accept anything new easily, and to conduct such trials, like a trial on ivermectin, no company will be so much keen to do it because it is an out of patent drug now. So something which has come new, for example, like these monoclonal antibodies, if they are able to sell at a price of 1,20,000 rupees, that much money has gone into the research, and now they are pumping in, and now the pharma companies trying to recover the whatever investment they have done. But such a thing cannot happen for drugs like ivermectin, because it's a drug which has gone out of patent. So the price of ivermectin is very less. But if you have to intelligently use it, I was coming back to the same thing. If tomorrow government of Goa decides to just deworm whole of Goa with ivermectin, and they say that we are not giving for COVID, we are giving for deworming. And on that, nobody can go on a petition and then can ask you to withdraw that kind of a thing, because deworming with ivermectin is definitely valid. If you go on Google also and check on that, you will be able to see that as a treatment of ascariasis, ivermectin is seen under the CDC recommendation also. That is American disease for Center for Disease Control also recommends ivermectin as a treatment for ascariasis. So tomorrow, if you say that this is the rainy season which is going on, and because in rainy seasons we are expecting people to suffer from worms, and we want to control the worms by giving ivermectin, you may be able to actually do good for COVID, which is a thing which you have to observe. But as far as ascariasis is concerned, nobody can really challenge in the court of law that why this was done. And this is not my idea. This has been done in other countries like Mexico and Paraguay also. In country like Paraguay, one of the provinces, the local governor there used this idea, and he actually dewormed the whole of that province. And it was strikingly found that compared to other areas of the same country, that particular district or the province, the COVID rate was significantly less. But he had posed it as if he is giving as a deworming treatment. So if we have to follow this idea, you can, as a doctors can recommend your government and do this as an experiment. See, because without doing such experiment, we will not have any data. Right now also what we are talking is all Western data, Western studies, and on the basis of that, whatever the analysis is being done, on basis of analysis, we are just drawing conclusions. And on the basis of those conclusions, we are saying that no, this drug cannot be used, or it can create problem. Because if you see the side effect profile of this drug is minimal, hardly any side effect. I am myself taking it regularly, at least on individual basis. I have not found any kind of side effects. And if anybody of you are also is taking, can also share his or her experiences with taking ivermectin. So that is where we are. Can we move ahead, or any more questions, Samuel, doctor? Your voice, I can't hear you. Well, I can't.
Can you hear me now, sir?
Yeah, I can hear.
Can you ask me the question?
No, if you want to ask any more questions, or shall I continue?
Yeah, one sec. I'll just check, sir. Any questions are there? Is there a fixed time or period during the infection for giving monoclonal antibodies?
Yeah, that's a very good question. It is said that as soon as possible. The words used on this same reference that I have been quoting, that is uptodate.com, is that it should be given as early as possible or as soon as possible. But then for that, we have to be finally choosy, because the drug being so expensive, we cannot keep using left, right, and center that everybody gets cough, cold, and fever, and it is appearing like COVID, and you just get your RT-PCR done, and it comes positive, and tomorrow you give the patient monoclonal antibody. That cannot happen unless the price really significantly comes down. If this price of 1,20,000, if it comes down to even 12,000, we may be able to still think of giving it. But even still in resource limited setup, it is going to be difficult. So
there's one more question.
Yeah.
Recently, they have recommended cocktails of the monoclonal antibody during first 3 to 4 days from the symptoms, rather than just monotherapy with monoclonal antibody drugs to avoid serious complications, manifestations of COVID-19. I would like to understand how good is it to start the cocktail of these medications, because the adverse events with these monoclonal antibodies are also severe.
Yeah, adverse effects, actually we are all gaining experience, but they are not very, very severe. Whatever has been used in city of Mumbai, as we are talking amongst ourselves, we are not seeing very severe side effect. Cocktail is the drug which is right now being used. They're really tongue twister names also. Casirivimab and imdevimab is the cocktail that is used. So casirivimab and imdevimab is the combination which is used, and these drugs they are being given as early as possible, like within first 3 to 4 days, and then the effective, like it is still not really approved for using in hospitalized patient, because hospitalized patients are the one who have really got already serious and complicated. So that stage, we have missed the bus kind of. So if we have to control it, the way in which they are acting is that they are blocking the spike protein. So the spike proteins are getting blocked so that the virus does not enter into the cell. But once the virus has entered and already the phase has reached to a stage of cytokine storm, and the patient is on oxygen and all, then it is too late. So if you have to use it, we have to use it early, and this cocktail is what you said is correct. That is what has to be used. Only important point to be remembered is that this particular cocktail that I mentioned is effective against all the variants of concern. As you are aware, this alpha, beta, delta, gamma, epsilon. Now there are 5 variants of concern that we have, and all of them, in fact, initially there was a different cocktail which was more popular. That's again as a big tongue twister name starting from B, bamlanimab, and all that. But that drug has been withdrawn in US because it is found that it is not effective against the current variants of concern which are active in United States. So
sir, is this the same cocktail which President Trump took?
Trump had used, correct.
Okay.
Yeah. But that is not effective now. So even this current which is effective, for if you have some another variant coming after some time, maybe it may also lose potency at some point. But at this moment, this particular monoclonal antibody cocktail is active. It is effective. So if we have to use it, we have to use it for right kind of people, and especially those with comorbidities. People who are suffering from cancer, people are suffering from diabetes. I think there's little noise on my side only. There's some drilling work going on. If you just permit me for a minute, I'll just close the window. Just give me a minute. Yeah, I hope the noise will be less now. I just close the window. So this particular cocktail that we are talking, I hope it continues to show its efficacy for long, and for those who are really having severe comorbidities in form of diabetes, like severe diabetes or severe hypertension, or people with pulmonary hypertension, people with COPD, people with cancers, those who have undergone transplants, people with HIV having low CD4 count. So these are the people who are at high risk, and especially out of those who can afford the treatment, can definitely be offered this treatment. Like in city of Mumbai, we are seeing that in Breach Candy Hospital, which is considered as a hospital from South Bombay, where more affluent class goes, there the usage of this medicine is more, because obviously there the people are coming there, are affording it more easily. Similarly, I know in Goa also you have a good affording class who may be able to use this. But for the resource limited setup, obviously this drug cannot be used at this juncture. So that is the big limitation that we have. So any more question, or I will continue with my discussion? Okay, I will. My most important point that I want to make, as we are here in the resource limited setup, is that, and you are also initially mentioned that patients with fever, they start coming to the family physician, doctors, clinics. Now, as you know, this COVID is a virus which has a very high secondary attack rate. Now, what do we mean by secondary attack rate? Secondary attack rate is where once you are exposed to that virus and the virus enters your body, the chances of catching that infection or chances of developing the disease is very high. Now, in that scenario, when the disease spreads so rapidly like a wildfire, getting exposed to the patients in our clinics is a very dangerous thing as far as doctors are concerned. And that's why many doctors have lost their lives primarily because of this reason, because kept on getting exposed to patients. So on this front, we have to, I want to share some thoughts, but if you have anything to ask me.
Sir, before that, I have some 3-4 questions pending here.
Yeah, please.
I'll read it all together,
Yeah.
and you can answer it. Are there any contraindications to ivermectin? The next question is once a week prophylaxis of ivermectin better than once in 2 weeks or once a month? And when would you stop, since there seems to be near end of COVID pandemic? The next question is there a loading dose of ivermectin for prophylaxis? That is the dose of ivermectin for treatment? Next question is how long the cough of COVID exists? When should one go for further investigation? Next question is how about low dose radiation therapy? You can answer in your
Fantastic. Okay. So let me complete the ivermectin story. Now, as far as this once a week, twice once in 2 weeks or once in a month, I don't think there's a very good trial on that. The jury is still not out. I am taking once a week. If you are okay taking it, I would say just continue. But even if you forget a dose taking, say if you have actually forgotten to take it exactly on the 7th day or 8th day, take it after 10 days, take it after 15 days, keep taking. Right now, intermittently, if you take it, fine. Loading dose, yes, you can take initially for 3 consecutive days. If you have not started at all, and if you are now going to start it, you can take on 3 consecutive days 12 milligram, and then you can make it once in a week or once in 2 weeks or once in a month, the way you wish to take. Like this one of the statement which I heard, that we are almost nearing the end of this pandemic. That's really a wishful thought. I also pray to God that if it is a fact, then we are really happy. Just one hint that I am getting, I am not trying to make you casual about it, but at this one hint that I am getting in the city of Mumbai, and also I think you are also seeing in Goa, that the fever cases have increased right now. We are seeing fever cases coming to our hospitals, to clinics, and getting admitted. But those fever cases, they are not of malaria, they are not of dengue. They have typical viral-like feature, myalgia, body ache, cough, cold, sneezing, everything is there. And I have got their H1N1 study, that the influenza RT-PCR done for these patients, for at least 7 or 10 of them. And most of them have come positive for H1N1. So there is an H1N1 kind of a semi-epidemic going on in our area of Mumbai, and I'm thing you are also seeing in Goa. As I was talking to Dr. Samuel, he also shared with me. So my only thinking about this issue is that, though, as we know that even influenza also spreads by the same method. It spreads more of an airborne method, though we are talking that the COVID spreads more with droplets, and that's why the 6 feet distance approach actually came in. But then influenza spreads more like with airborne spread. And if influenza is spreading, but we are not seeing much of COVID cases happening, so is this the effect of vaccination which is happening? Because the COVID vaccination numbers are now increasing and our overall herd immunity must have increased because of the COVID vaccination, plus the second wave which came where many patients suffered. So collectively, our population's COVID immunity has gone up, but that much immunity is not there for influenza. So that's why influenza cases are spreading, but COVID cases are not spreading. So if we continue to maintain this vaccination pressure, and also we continue to maintain our COVID appropriate behavior, this end of pandemic may be possible. So that was the good news that I wanted to share at the beginning of my talk. I was going to come to that. ये वो story का climax है कि वो ये हम लोग करेंगे समझो. If we continue to maintain our vaccination and if we maintain to continue the COVID appropriate behavior, we may not need any medicine and this disease can be controlled. But for which we as doctors first and foremost have to follow the COVID appropriate behavior, because we have to set ideals in front of our patients. Like we as doctors start holding conferences where we start meeting together, we start having lunches together, we start having dinners together, we start having some other music function. But this all happened in month of January, December of that past. And if that story gets repeated now after next 2-3 months, for all you know, again the trigger will start, and it's like a wildfire. As I told you again about that exponential curve. Initially, we will be in that false hope that okay, the disease has gone, but numbers will gradually increase, and then suddenly there will be a third wave which may come. So if we have to avoid this, we have to follow that. There were some 2 last questions which were not related to ivermectin. I think I probably did not answer them. Can you mention them? Your voice is not, I can't hear you.
Now you can hear me?
Yeah, I can.
How long the cough
How long the
of
cough?
COVID exists? When should one go for further investigation? The
Right.
next question was, how about low dose radiation therapy?
Low dose radiation therapy, I have not heard of that also. So I will not take that question, because radiation is something which is very severe, but I don't know exactly which reference the doctor is quoting. So I will not take that. Cough is a very good question, because there's something like post-COVID syndrome that happens, especially with people who have suffered the severe disease, can go through a post-COVID syndrome. And the cough in such patients can last up to sometimes few weeks to few months as well. So it is more like a post-viral tracheobronchitis that develops. And if not that, if it is more severe, then it is post-ARDS complications which have occurred, and that can also cause dyspnea and other things. So the therapy for such a cough is generally in form of giving inhaled bronchodilators and all. We can use inhaled steroid also, which can help them too. And more than that, just the symptomatic treatment with dextromethorphan and maybe some amount of even codeine can be used if it is available easily there, but with a warning to the patient that this is not to be abused, obviously. But these kind of cough suppressants really help to control the this COVID-related cough which can happen. And if you are really finding beyond a certain time also, if it is like, say, for example, beyond 1.5 months, if it is not happening, not getting controlled, obviously you would like to rule out other causes of cough, which can be in form of even tuberculosis, which can be in form of some other gastroesophageal reflux causing cough, or it can be even simple worms which can lead to cough. So it's a long possibility of differential diagnosis that we can think of. So that way speaking, you can always investigate the patient. Here comes the role of the CT scan also. I wanted to take up that as a point, like when to do the CT scan in our COVID patient, because we found that CT scan probably got overused, especially in cities like Mumbai. I don't know what was the scene in Goa, but here the centers have mushroomed everywhere, and the patients also started knowing about CT scan, and especially the severity score that came in picture. So people knew that मेरा कितना score है out of 25, how much I am scoring. So people on their own were kind of putting a little pressure on the doctors also कि मेरा भी CT scan करवा लो. And when there was hardly any treatment to offer, no doctor wanted to actually say no to that. अरे नहीं आप करना है तो कर लो करके. But if I have to tell you that what is the current jury on CT scan is, and this is again I'm quoting uptodate.com, and the latest that I have seen that in America, CT scan is very sparingly being used. It being an expensive investigation also, obviously there the pressure on the insurance system also cannot take the brunt of doing so many CT scan. In India, we have relatively less costing for CT scan, so we sometimes tend to sort of overuse it. But there is obviously excessive, because of the radiation risk also goes up. And the confusion also is created because of CT scan, because the severity score does not correlate with the patient's symptoms always. So it is that the person with the score of 8 on 25 and a person with a score of 15 on 25, it's not that the 8 on 25 is always milder than the person with 15 on 25. So there is a lot of intricacies in that. So it is most important that we go by the patient's symptoms and not by these imaging studies and not by only the investigation reports. As I'm coming to that point of doing even the blood testing, people got confused so much because of the IL-6 studies which were done, that is interleukin 6, just because the number is rising, there was a scare amongst the people, and then they got admitted, or they also took a more sort of aggressive therapies like remdesivir or even tocilizumab. All these things sometimes happen purely because of the number game and not actually because the patient was clinically worsening. So all these factors put together, we have to take the decision for whatever therapy that we are offering.
Sir, regarding ivermectin, lastly, the question which I read it little wrongly. The member says it actually had to read no near end, but it's good to know the speaker's thought. Great discussion, thank you. And he writes, I meant to know for how long can we safely keep taking ivermectin. I too take it weekly, and this is because new variants keep coming up, but wondering how many more months can we continue, that's all.
Yeah, that's a very good thought, and I really appreciate the way you have been liking the discussion. And we really don't have an answer to this question. But at this juncture, in my opinion, next 3 to 4 months are very, very critical. Like if we can hold on for these next 3 to 4 months and can maintain this kind of a status of a very, very low transmission, which is going on in our country at present. And if we can really bring the numbers to near zero, then we have achieved it. Till that time, I think we can continue taking it. And the vaccination number, as it starts increasing more and more and the herd immunity goes up. See, technically speaking, we should have at least 70 to 80% population should get vaccinated for it to call as a very good level of vaccination. So I am told that cities like Bhubaneswar and have really completed 100% vaccination, and Mumbai is also gradually sort of inching towards that. It may happen somewhere in month of November. Somebody was mentioning that day. So we can take it at least till that time, maybe November, December, if I had to tell you right now. And it will all depend on what the future happens in it. So that's all. Yeah. Anything new, or I will come to my. So I was till you read the question. Let me put forward my next point, where I'm trying to encourage telemedicine amongst the general practitioners. So I would like to have discussion on telemedicine now, because that is the way we can actually avoid getting these patients out of their houses and coming to our clinics. Because that particular action that the patient takes, because obviously somebody who's ill would like to reach out to the doctor as soon as possible. And for a general practitioner, where if there is no proper appointment system being followed, if it is like a walk-in type of a OPD which is running, the patients will just walk into that OPD and will create crowd. I mean, I keep seeing this happening in city of Mumbai also. I mean, there is one very successful general practitioner who's I just passed by that clinic sometime, and I see that outside that clinic there is so much rush. The patients are just standing there waiting for the doctor to come or their numbers to come, and that is a bit sad scene that I feel, because patients, when they're standing there, obviously there is a risk of transmission happening to each other, and they have traveled from their houses, they have come to the OPDs, and that has created problem. So when everything is now happening on phone and when things are happening online, people are ordering their food online and so many things are happening online. Maybe the lower strata of people may find it still difficult. I'm not just saying that it is not easy, but if we doctors get into as a united practice, because when I was talking to some of my general practitioner friends in Mumbai, and I was trying to encourage them to have telemedicine practice, तो से अबे वो झोपड़पट्टी से आएंगे और समझो ऐसे फोन पे सलाह लेंगे तो हमको पैसा कैसे मिलेगा? Like, who will pay my bills? Like, if I start giving them medicine on the phone, how will I get? Because they are sort of dispensing medicine. So if you are in that kind of dispensing practice, and all kinds of things I have seen doctors doing, like patient would come to the OPD, the doctor is inside their room, the patient is standing outside, then there is some big bench in between so that the patient does not reach up to the doctor is wearing some face shield, there is no proper air conditioner, doctor is sweating inside with a mask on, with gloves on, and the doctor is becoming so miserable in this whole process and just trying to help that patient. He will just listen from a distance, aapko kya ho raha hai? So anyway, the doctor is not putting on a stethoscope or is not even checking the patient's pulse, and with all that you are just calling the patient to your clinic just for him to pay, make him pay, and then the payment is made in some box which is kept outside the clinic. One of my doctor's friend is to actually not open that box for 1 week, full 1 week the money will remain in that box, and then he will take back the box home and he will actually put that box in a pressure cooker, and he will actually autoclave that box and then see that the currency notes are sort of COVID free, or some doctors have even done the ironing of the notes also to make them COVID free. So to avoid all this, now with the electronic money transfer becoming so popular, why not we as an association, like I am holding a talk for an association. So the association decides and convince their members to do this, that for flu-like illness, may it be COVID, may it be influenza, but for flu-like illness, we will have only telemedicine and over the phone. And then we have the protocol for how we follow telemedicine. I have got that full plan in my presentation, which I can share with you, what we can do and how we can judge those patients. But this one important thought I want to plant, and I want to have opinion. I want to know, I mean, if Dr. Samuel, you can say something about what.
Sir, IMA is our body and all our GPA members are also IMA members. So IMA last year on the first wave, we had done this program of teleconsultation, and it was very much successful, which prevented the patients to come to the hospital. And our members really took lot of pains, and and even we involved dental association, Ayurvedic association and homeopathic association, and with all together we did this, and it was really a good success on the first wave. Second wave, what happened is nobody had time, everybody was hectic, everybody had a lot of patients and everybody were busy, so that could not be that successful on the second time. So I think, as you say, now when we are free, this we should
We can start
We
preparing
should start
ourselves. Like for example, how I do it, I will tell you. What I have done is, I have made one questionnaire. So if I get a call, for example, the call goes to my clinic first, and my receptionist picks up the phone. She will ask few questions to the patient and try to find out whether this is a fever case, and that too fever case with some respiratory symptoms or maybe some GI symptom, which can also happen with COVID. And if she gets that kind of feeling that it's an acute fever case, दो महीने से बुखार आ रहा है और 2 महीने से खांसी चल रही है, तो those kind of patient she actually are allowed to come to my clinic also. But नहीं 2 दिन से बुखार है, आज कल रात से बुखार है, those kind of cases she would say that please call the doctor, or you send a WhatsApp message to our doctor. She will share my mobile number with that patient. Now, as the patient calls me or as the patient send me a message, if they call me especially, I will tell them, please do not describe your long story. I will be sending you a questionnaire, which I made in different languages also. But most of the people now understand English, so English was not a big problem. But somebody who did not understand, I even translated in Hindi and sent. And I told them to reply to that questionnaire and send it back to me. And on the basis of that, I could actually do the triaging, because this is the word used is triage. You have to see that which patient is doing what. Now, the best part is that most of our people have got this pulse oximeter at home. So with the pulse oximeter being there at home, we can get an idea. If the patient types back and sends back to me saying that his pulse oximeter is showing a reading of 93, he will be the patient where my phone will go immediately. 93 means gadbad. If it is below 95, as you all know, below 95 is gadbad. So that kind of patient, I will obviously go into details more and try to encourage them to send them for admission. And also about other parameters, like if you have the comorbidity, my questionnaire I will surely share with you, Dr. Samuel, on WhatsApp. You can send to our members also.
Yes, sir.
You all also must be doing on the same lines. But if there's anything new that if you can pick up from that, or if you can also share your approach with me, we will all jointly do some work whereby we can safeguard ourselves. Because in second wave, also I was also extremely under pressure to work, and as a family physician, maybe your number of cases must be much more than what I was seeing. As a consultant, we get slightly filtered cases, but as family physician, you get more number of cases. So there, in fact, my wife and my daughter also helped me to see the WhatsApp messages. In fact, what we were doing, I used to see on phone, and the same phone WhatsApp can be seen on the laptop also. So they used to see on laptop, and then they would kind of filter the messages, that which message needs to be seen by me immediately, which need not be seen. So all this kind of work we could do, but then somehow we have to protect ourselves, because if we keep getting exposed to all the patients like this, the doctors have fallen ill because the same reason, no? Because our exposure to the patients, when it increases beyond the limit, it becomes very difficult to sustain, and then your immunity cracks at some point.
Sir, regarding ivermectin, there are 2 more questions.
Please.
Contraindication
Yeah.
to ivermectin, especially hypertension and IHD. And can we give ivermectin prophylaxis to pediatric or teens? And if so, dose?
Pediatric and teens, yeah.
And sir, can you?
It is very much allowed. See, yeah.
Yes, sir. Go ahead.
Pediatric and teens is allowed. There is no great contraindication. That way, every drug can cause some allergic reaction in certain population of people. But otherwise, if we see, there is no great contraindication of ivermectin. And as you know, there are the brands which are there. There are some brands which are there in market have a combination of albendazole and ivermectin. You must be aware of such brands. And there are 2 dosage strengths are available. There is one brand which is a if I'm allowed, I can even say the brand is something called a Bandy Plus. So there is something Bandy Plus and Bandy Plus 12. So the one with 12 is for the people who are above the age of 60, and those which are below the weight of 60, not age, weight I'm mentioning. Weight. If it above the weight of 60 kilos, you use the 12 brand. Otherwise, you use the lower brand. So teens can definitely take. There is no problem. And even in children, it is permitted. It is not a contraindicated drug in any population as such. Only maybe pregnancy we will definitely don't use such drugs, but otherwise we can use in all the population.
So this question, sir, can you throw some light on post-COVID psychological issue? Sir, for how long time low dose aspirin is to be taken?
Yeah. Low dose aspirin, I'll just complete. Low dose aspirin, in fact, did not find any role in the management of COVID after a while. There was a phase in which we were using it, and it was used kind of as a substitute for anticoagulants, in fact. But as you know, that it is an antiplatelet drug. Aspirin is not an anticoagulant, it is antiplatelet. So it was found that because COVID causes hypercoagulable state, it can cause blockages in the arterial circulation, especially in the lung parenchyma and all. And it can also cause pulmonary embolism. It can cause DVT. This was found. So that's why the whole role of this D-dimer came in picture, and we kept on doing D-dimer for many of our patients. But over a period of time, it was realized that for just minor increase in D-dimer, there was no need of giving even anticoagulants. And only when the D-dimer was going, say, 3 times or 4 times the upper limit, let's say upper limit is 500, then if it is going 3 to 4 times, then only there was some role of giving anticoagulant. And otherwise, the role of aspirin, which in fact had created a big noise, but in the current literature, again, I'm going by literature because we ourselves as doctors don't do any research as such. So finally, we have to depend on what the world literature says. And again, if I have to quote this uptodate.com, which I have again read it today morning before appearing for this webinar, there is no mention of aspirin as a therapy, but those who are already taking aspirin, it should be continued. That is the message that goes. So those who are on aspirin for cardiac problem, those who are on statin for cardiac problem, those who are on, say, non-steroidal anti-inflammatory drugs for some reason, those who are on ARBs as an antihypertensive, all can continue their drugs. Because about ARB, there was a little confusion which had come up initially because it is going through the same ACE receptor. This virus enters through the ACE receptor. So there was a confusion about whether we need to stop the ACE inhibitors and ARBs, but there is nothing of that sort. All these drugs can be continued. Only issue is about the immune modulators and steroids. So if somebody is on immune modulators and steroid going on for a long time, and if they are suffering from COVID, if it is possible to reduce the dose with the consultation of rheumatologists and all, we can do that. Otherwise, continue those dosages also. The psychological aspect of the question which was asked, it is like post-traumatic stress depression that one can go into. It can be anxiety. It can be a cognitive confusion state, that is the brain fogging that we call it as. All these things over a period of time, say within few weeks to months, they subside. So generally, none of these things should go beyond 4 to 6 months. So that much of a time period we can give. And obviously, whatever therapies are required, they can be offered to the patient in form of counseling, in form of some actual psychiatric help, or the social support that we can create for the patient, even as we have to basically give them the ray of hope, the most important. And I would again take this opportunity to say that we should encourage them to start doing exercises, because this one pandemic has told us the age-old dictum that Charles Darwin had told us, that is survival of the fittest. Only those who are fit will survive this pandemic. So if we have to improve our fitness, we have to do certain things. The fitness just doesn't come from outside. It has to start from within. So losing the excess weight, doing regular exercise, the practices like good yoga and pranayam, sleeping for 7 to 9 hours properly at a stretch, especially trying to find out the people who may be suffering from obstructive sleep apnea, because people who are suffering from OSA have also been shown to suffer more from COVID. So we have to really take extra effort to find out people who are suffering. And that's why even the obesity becomes a major this comorbidity. The people with obesity, there is a strong link between obesity, diabetes, hypertension, OSA. All these things come as a package. They're like metabolic syndrome that we talk of. So such people, we as even doctors have to encourage them and give them this strong message, because it has been seen that when somebody goes to a very difficult times, that is the time we can take them away from addictions. Like somebody who's been a smoker and gets a bad heart attack and has to undergo a angioplasty or bypass surgery, that life-changing event can help the person to quit smoking. Otherwise, our advices are just Marathit म्हणतात की आपण पालथ्या गड्यावर पाणी. We keep telling the patient, but they don't sort of listen to us. But these health promoting advices have to go from the doctors to our patients in some form or the other. So in fact, I have made some messages also. I will share again, and I have sent some to Dr. Samuel, which I will request him to share with our doctor friends also, where I have talked about the COVID appropriate behavior, but at the same time, these health promoting measures by which we can improve our body immunity. Once the immunity improves, then only we will be able to control the pandemic much better. So those who are going through psychological problems should be also definitely encouraged to go through all these things. They have to start thinking in more of realistic manner. Our current generation, we are forcing everybody to be positive. We want to achieve something more every now and then. We want to increase our every quarterly profits. Our companies want to get more money. But this completely sort of money-driven scenario that we have been living in, this COVID has given a big jolt, I would say. It has made us to sort of rethink that what is the true wealth. As we have been just saying, health is the true wealth. But then that we have to really implement, and we have to just follow that. Any more questions coming?
Sir, there are a lot of post-COVID hair fall patients coming in.
Yeah.
We have been giving them only advising high protein diet and protein powders. In spite of that, can we give them something, and how can we treat this?
Post-COVID health. That, I think whatever that
Hair fall, sir.
Hair fall. Yeah.
Hair fall.
Question. Yeah, hair fall post-COVID is a common observation. It is not a permanent alopecia that they will develop. It can be in form of a generalized hair fall. Even a lot of women also have got bad hair fall. But the hair is actually, they are growing back. As you must have seen, especially the senior practitioners who have seen many cases of typhoid in their lifetime. Even after a serious illness like typhoid, there is a lot of hair fall which has been seen by people. And the reason for which is that when somebody undergoes through a serious disease, all our hair roots, their growing cycle somehow gets timed at one single point in that time cycle. Generally, what happens if you have millions of hair roots, they are growing, their hair growth starts at different time period. That's why the hair fall also happens at different time. On one single day, we don't find all hair are falling in a big bunch. But when such an illness happens, somehow their cycle gets synchronized in such a way that many hairs start growing on one single day, and those hairs start falling after a particular time. So after some period after this illness has occurred, you will feel that suddenly there is a hair fall, but those hair grow back. And then you can give some supplements like even biotin and all. Biotin helps. You can ask them to have overall multivitamin, multimineral tablets, and plus all other good health measures that we just now discussed. With that, the hair will grow
So
back.
does high protein diet helps in hair fall?
It will help. Why not? Because after all, proteins are required for growth of any new tissue. So if high protein is given, it will help. But you can add biotin also to that. You can add iron to that, because many women are actually iron deficient, or even folic acid can be a problem. So iron deficiency also causes hair fall. So especially for women, we can encourage them to have iron supplements also along with it. Yeah.
There's one more question.
Please.
Can you shed some light on the treatment of lung fibrosis and post-infective fibrotic sequence?
Yeah. So the most important part is that it all depends on how severe the disease occurs. So if it was a bad ARDS, such people are going to have fibrosis. So the therapy which starts in the hospital obviously is most important to reduce the fibrosis. So the dexamethasone, which came in a big way as a therapy of COVID, and this was found out in the recovery trial in UK that giving 6 milligram of dexamethasone made a difference. So giving steroid at the right time when the patient is requiring oxygen has made a lot of difference. And then we may have to, in fact, continue the steroid for a longer period of time for those who are developing fibrosis. The role of antifibrotic drugs like pirfenidone and nintedanib have been always in picture. We have been talking of giving these drugs. They do help if it is given at the right time, either as a combination of two medicines. Also, people have given, or only pirfenidone also works well. So I have used for my patient pirfenidone, and they have recovered. But there are many case reports which have said that people have the fibrosis has resolved over a period of time, even without these medicines. Also, there is a good chance that it will reverse. But patients who have been requiring oxygen at a high dose, even at discharge, if they are requiring hospital oxygen and their CT scan is showing definitely fibrotic changes, that is where the role of CT scan becomes important. If we demonstrate the fibrotic changes in the CT scan, then the role of antifibrotic actually comes in picture. So I am in favor of using antifibrotic, and the drugs which I have told you, that is pirfenidone or nintedanib.
So you can start with your.
Yeah. So the questions are sort of over. So I am.
So basically, the patient nowadays we are seeing a lot of influenza. So it's a really confusing stage now. Patient comes with a fever, and patient has a lot of anxiety that it is not a COVID or whether it's a COVID, and even we feel we should not miss it. And then some patient doesn't want to do COVID test, or should we unnecessarily send them for a COVID test? So just highlight us in the clinic atmosphere how we as general practitioners see a lot of fever patients, flu patients. So let us just put some light on all those small practical things, how we can sort it out, when the blood test is required, when COVID test is required. Should we send the patient, call the patient after 2-3 days? Should we wait whether the fever should go or no? All those things, sir.
Yeah. So the flow, I will just describe the whole flow. First and foremost, I would again beg to differ on the point of calling the patient to clinic. So if you can really avoid calling the patient to clinic, nothing like it. That is the best way you can protect yourself. You can protect your staff. And it is not only you and your staff, it is also the traveling that they are going through. That person is traveling through some rickshaw or something, so he's exposing the rickshaw driver. He's standing, he's sort of waiting at your clinic, so he's sort of mixing with other patients. Somebody with malaria has come to you, and or somebody with pure diabetes has come to you, and he has no COVID, but this patient with fever will come and sort of sit next to him, and he will transmit the disease. So as far as possible, these patients should not come to you. They should be, we should talk to them on the phone and see. If we have to empirically start a treatment in this time that we are going through, I would say that if it is sounding very much like flu, which is in form of runny nose and severe body ache and cough, everything is there with upper respiratory symptoms, especially, or even loose motions, because loose motion can be a symptom of influenza, I would put this patient on oseltamivir. Okay, I start this patient on oseltamivir, which works wonders. It works well. It's a good antiviral drug, which definitely works against influenza. So unfortunately, such drug against COVID was not easily available, and we always wanted to get some drug and use, like even favipiravir is also a drug which has an anti-influenza action. It was launched in Japan for influenza only, and then it came for this other indication. But for such patients of yours that you are describing right now, what we are seeing so much commonly in community, what I advise them, especially on telemedicine, is that I start them on favipiravir. I give them symptomatic treatment with paracetamol and all. I may give them azithromycin if you are suspecting a viral, bacterial pharyngitis, but not every patient actually requires azithromycin for that matter. And then some symptomatic cough syrup and all. Now, what I am writing right now in my message, this is exactly the message. What I do is I save these messages in the notepad on my phone, and then it becomes easy to quickly send them to our patients also. You may have to do little modification because that saves time. So these are all tricks of the trade that I am sort of sharing with you. You all also must be doing this something on similar lines. So I send these messages to them, and I write there that if your symptoms persist, you do the further testing. So if the symptoms are persisting beyond a day or two, then I tell them to do a COVID swab test. And I also mention about doing H1N1 swab test. But H1N1 swab test is costing 5,500 rupees. So it's a very relatively expensive test. Comparatively, COVID swab test has become much economical because of the workload that has increased. So it has come down to something like 800 rupees that is being charged in Maharashtra. I don't know how much in Goa it is being charged at. So that way we can get the COVID test done if the patient's symptoms are not subsiding. If there is any slightest of doubt that this may be due to malaria, then we should obviously get a malaria test done, because if we don't do malaria test and if we miss malaria, then it is not a good thing to have, because that's definitely a treatable disease. Dengue, obviously, if the patient is not responding, at some point we should do the dengue antigen also. And one rule of thumb I can tell you is that if the patient has no respiratory symptoms and patient has fever, if there is absolutely, because we bilkul khasi nahi hai, bilkul sardi nahi hai, but I have body pain, but I have other symptoms, I would tell them to do their dengue and malaria outright initially. Otherwise, I would put them either only on symptomatic treatment, or if I have to offer them something, I will do. I will put them on oseltamivir. So I don't know how much is the usage of oseltamivir in your practice, Dr. Samuel. If you can help me.
Sir, what brand and what dose do you give oseltamivir?
Yeah, oseltamivir comes by 2-3 brand names. One is anti-flu, 75 milligram 2 times a day. It's a capsule. Or it comes by the name as Fluvir also, Fluvir or anti-flu. And there are some more also, Encosvir or something used to be available, but I don't know what is available in Goa commonly. But these brands are there, 75 milligrams 2 times a day.
So this we use it. We use this very frequently, sir.
Pardon me?
We use this very frequently.
So continue using that. That is what is the best therapy for flu, I would say. And patients do respond to it well. That is a good drug to give. And thereafter, most importantly, on a telephonic advice, I tell them to keep following up with me. So even for COVID patients, what I do is I get few of their blood tests at the outset, but I don't do too many tests. CBC, CRP, SGPT, creatinine, one random sugar, and urine routine. And if in doubt, I may get their TSH also done, because sometimes even a thyroid can present as fever. But just so these few 5-6 tests are enough. We don't need to do LDH. We don't need to do IL-6. We don't need to do D-dimer. All these are unnecessary, increasing the cost. So CBC, CRP, SGPT, creatinine, random sugar, urine routine. Even if we do these many tests, even for the case of COVID, it is good enough. On basis of this, we can take a call. If the patient has more comorbidities and the patient is elderly, appearing sick, you can get also electrolytes done. If the patient is diabetic, you can get HbA1c done, because then you know how has the patient's diabetes control been. So such a patient can be advised to get hospitalized early if it is required. But by and large, for a general average patient, somebody who's from a slightly low economic strata, where we don't want to unnecessarily burden the patient, will not get too many tests done. I tell them to monitor their pulse oxygen level at home. So having a pulse oximeter at home is definitely useful. But oximetry also can be at times little confusing. People with even normal looking oxygen saturation also can start becoming breathless. So I tell them to watch for their breathlessness. So dyspnea assessment is an important thing. And overall their level of weakness, the people who become very much weak over a short period of time, they are the one who are likely to give problems. So if they just stop eating food or they become very weak. So even patient with influenza also can die. As we know that we had gone through a swine flu sort of epidemic in 2009, and thereafter this swine flu has sort of remained in our community. So people with influenza with comorbidity also can die. So those who are showing these kind of pictures of extreme weakness, too much of vomiting, not eating food, and becoming breathless, if there, and even for that, especially even a voice call with your patient, or if possible a video call with your patient, helps us a lot, because if you see that patient is using accessory muscles of respiration, this type of behavior, I mean, if you can pick up on the phone immediately, you can tell them that this patient will require hospitalization. So such a patient, I would say, if you really feel is necessary, you can call them to your clinic and you can examine. Or best is don't even do that, send the patient directly to the emergency department of any good hospital, and there obviously the doctors who are examining are covered up in a proper PPE kit and all. So they are wearing PPE, they are sort of protecting themselves, examining the patient, and such patient gets admitted. And then thereafter, after the admission, the treatment, whatever is necessary, is given in form of oxygen, maybe in form of pruning, remdesivir, because remdesivir also plays an important role, as you know, that if we pick up the case within first 10 days and the patient is requiring not even requiring oxygen, but the patient's oxygen level has started dropping. Say it used to remain 98, but now it has become 95. So even these drops of saturation also are important that we pick up. So this doctor's role as a general practitioner, I feel, is a right advice at the right time, because after all, time is money and time is life, I would say. So if we can pick up these cases who are likely to get complicated at the right juncture and send them to the hospital and get them treated. Now, the common question that I guess asked is about use of steroid at home. I was surprised how come that question has not come up as yet. But are you giving steroid to your patients at home, or oral steroids? Or have you used in your first or second wave? What has been the trend there?
Yes, sir. Yes, sir. Steroid has been used very free. Yeah.
Now, there the confusion is that if we see the literature, if we quote the literature, again I'm coming to that uptodate.com, it is right now the jury is that don't give oral steroid when the patient is at home. That is the message that goes on. Start steroid only when the saturations have started dropping. Now the obvious next question is that if we don't use steroid, do we allow the patient for him to get his saturation dropped, and do we allow the patient to reach hospital? So what is the right time to give steroid? So that is the most challenging thing that we have to answer.
And our second wave, we were not giving the steroid on the first visit. When patient used to get breathless or fever was not subsiding, that was the time we started steroid and favipiravir. So now this is a question whether we need to wait or we need to start it
this
empirically.
is the most important point that we have raised just now, I would say. It's most important point. As far as favipiravir is concerned, whatever the world literature is saying, just sort of forget about it, because the drugs which are not available in USA, they sometimes just don't talk about it. But favipiravir is available in India. I have used it for my patients. If we have to use this drug, then it should be used as early as possible. So if you have to use favipiravir, whatever, the current trend amongst the experts in even the city of Mumbai, that favipiravir useless hai, usko mat use karo, it is it just doesn't serve any purpose and all that. But if we had to give something, because favipiravir also acts against influenza. So if you have to give something, use it as early as possible. Don't keep it as a reserve drug to be used on the 6th or 7th day. The reserve drug for 6th or 7th day can be your steroid. So don't, that little change in practice, if we can bring, that is fine. Similarly, ivermectin, if you want to start it on day 1.
Sir, you mean that a patient with a positive report,
Yes.
no fever, nothing, you start favipiravir on the first day on the clinic?
So how will the patient come with positive report if he has no symptoms?
If some patient comes, even I had done, means what happens is like
These are the people who have done their test for some other purpose. Like if they
no
wanted
sir, one wife is suffering from fever,
wife is positive
and
he is positive.
and husband also does it, but
Got
he
it.
doesn't have fever. So
Doesn't
should
have
we
it.
start favipiravir?
I will not give.
Okay,
If
only
he is
fever.
asymptomatic, I will not use favipiravir. It's not it is like a preventive medicine that may use. I may give ivermectin with some whatever hope that it may give, but these are again still question mark drugs. But then if I have to give him something, I will probably give him ivermectin and not favipiravir. But as soon as he starts developing first symptom of fever, I will give him favipiravir as early as possible.
Do you give HCQS in such patients?
HCQS somehow now it has gone back, and now even the world literature says that HCQS doesn't play a role. But in pregnant patient, like I go to Adia Hospital, which is a prime institute for obstetric cases. It is an exclusive hospital for women in Mumbai. There we have a COVID ward. So there, when the pregnant women are getting admitted, we are giving them still HCQS as a treatment. So it is still a therapy which is being used for pregnant women, though international literature says that we need not give any therapy. Hello? Hello? Yeah, I think there's a little disconnect from Dr. Haya. Are you there? Yeah. So HCQS, as you said, I am not using anymore. The drugs which I'm using in addition to this is I would like to tell you are one is colchicine. So colchicine is a drug which has been used in practice of management of gout as well as in some cases of rheumatology, which is an anti-inflammatory action. So there has been a good trial which has been done on colchicine, though it is not supposed to be a wonder drug as such, but it gives some benefit. So if we have to use colchicine, we can give 0.5 milligram 2 times a day for 3 days, and thereafter continue it for further 27 days for 1 full month. It has shown that there is some faster recovery happening, but it is still not formed of a part of your standard protocol. Similarly, inhaled budesonide, that is a good drug which one can use to control the lung complications. So if we can give inhaled budesonide in form of either a capsule form, that is a rotacap form, or you can give in a inhaler form, 800 micrograms 2 times a day for at least 7 days we can use, 7 to 10 days. So these are additional drugs that I use.
Sir, one more drug is indomethacin. I have seen many doctors using colchicine and indomethacin in admitted patients. How indomethacin will help?
Indomethacin is not featuring anywhere in the current advice, I would say. Problem with indomethacin, it is NSAID. Now, NSAID is primarily were in fact initially thought to be contraindicated. They can cause complications. So that way, but over a period of time, the literature has said that those who are using already on some sort of a NSAID, we can continue it. But no indomethacin in hospitalized patients. And even in colchicine in hospitalized patient really doesn't play a big role. There, the role is more for tocilizumab or baricitinib, tocilizumab, dexamethasone, and remdesivir. These 4 drugs are recommended in hospitalized patients. And the role of baricitinib and tocilizumab is those who are already on dexamethasone but still not doing well. Their oxygen requirement is rapidly increasing, or the oxygen requirement has reached up to almost 10 liters per minute. These are the people where we have to use drug like tocilizumab. But that also has to be used very judiciously, because excessive use of tocilizumab and excessive use of steroid has led to many complications, especially this mucormycosis and all, suppressing the body immunity beyond a certain limit has finally led to all these complications of fungal infections. So we have to be careful using these drugs as well. About mask, I think we should say a few words, because as we know, that is the only shield that we have is the mask. So how we sort of protect ourselves. So even for doctors, and when doctors are advising their patients, I would say that we should strongly recommend the proper usage of mask. And as you must be observing, the usage of mask is a big area where we see a lot of loopholes, like patients wearing mask only on the chin, patient wearing mask at this level where the nose is open, patient wearing mask which is very loose where the sides are still open. So all these type of masks will not really give the best protection. So
there is one question about mask.
Huh.
Sir, which mask to use in medical colleges as offline teaching started? Students positive, but cases decreased. So in a nutshell, what would you start on day one? Patient has mild cough or no cough, fever and positive report.
Okay, so first case, I would the mask, I would say one should definitely encourage all the students to use N95 mask. Okay, N95 mask will properly cover the face, which has a clip on the nose. So once the clip is applied properly, there is no fogging of. If somebody is using a spectacle, one can make out. If there is no fogging happening on the spectacle, that means there is proper air seal. The N95 mask, especially the one with the string which goes behind, are more comfortable, which I use commonly for myself. The one which fits on the ear sometimes become a little irritating after a while. Somebody who is not very happy having it on the ear, I would say go more with the string one. There is a space inside the mask in which you can breathe. Now, the challenging thing is that we should educate our patients, as well as somebody from medical college asking this question. I would say you should even tell your students to have a proper breathing practice, so they can use the mask more comfortably. People somehow get little claustrophobic or they feel uncomfortable, but the studies on masks have shown that no mask can actually cause hypoxia. So when we are using a mask, it is slight increase in the work of breathing that happens. And if we get well adjusted to using that with a proper breathing exercises, especially the exercise like pranayam and the box breathing that we say, that we breathe say for 2 numbers and we do the exhalation for 4 numbers, that kind of a breathing exercise if we do, then the wearing of mask becomes comfortable. The masks which are having a vent or a filter on that should be contraindicated. Those masks should not be used, because there the source is still exhaling the air which can go directly to the other people. So there is no good source control in that. The person who is wearing gets protected, but he still remains a threat for others. So we should not use that. If N95 mask, if people are finding it a bit uncomfortable to use, let them at least use the surgical mask, which also has a clip on the top, which can be worn inside. And on top of that, a cloth mask can be worn. So that is called a double masking. So if they use double masking, the protection rate almost goes up to 87% or so. So that is again a good technique to follow.
Sir, how frequently the mask has to be changed?
Very good question. So what I do is, and which I followed right from last year, I started with 7 N95 masks. And this was shown in the video which came from All India Institute of Medical College. So I started following that. I started using 7 masks on day 1, and they were all kept in a paper bag, the brown color paper bag. And they were numbered 1 to 7, or maybe the days were written from Monday to Sunday. And then if I use the mask today, which is my Sunday mask, that same mask I will use only on the next Sunday in that kind of a rotation manner. And the same mask, if it has not got soiled or anything badly, you can continue using for definitely a few weeks to some months also, depending on your usage. So it's not necessary to just, and especially when the masks were expensive, the same N95 masks were at some point were being sold for almost 200 rupees, 400 rupees. Now the masks are available below 50 rupees also, this same N95 mask. So I would not like do use and throw for the mask on a daily basis. That's what I follow. And most importantly, what if we have to tell our students, say for example, medical college students or even any other person who is going out, we should strictly avoid eating outside the house. So we should start our day with a proper meal in the morning. We start the day with the mask on and we come back home and then only remove the mask. If we remove the mask for the purpose of eating, or if we sit together and have a group kind of a meal together, that is again a dangerous point. So all other times you may be using a mask, but for those 15 minutes or half an hour, you remove the mask for the sake of your lunch, and it can create a problem. So these kind of precautions we should try to tell. Definitely, all the parties and where people are sitting together and eating together should be avoided. Going to hotels and restaurants, I am strictly trying to tell others as well as I am not following that. People have started arranging some programs also in hotels. They have started arranging some singing programs also in the halls. But all that thing, I personally feel we should definitely avoid this kind of temptation. It is a temptation. Finally, this temptation will again bring us back to the third wave. So if we want to avoid the third wave, at this moment, we have to control our temptation and see to it that the virus is completely wiped off from our areas or our country. And
Sir, how is it possible? Goa are all 5 stars are full, marriages are started. How can we control this?
No,
How this awareness can be?
it all starts from us, within us. See, if what people are doing, we can just keep them educating. So what I would say is that the message which I have sent to you, if you send to more and more people, just let it pass on. See, there are people, different kinds of people are there. Some people are who will never improve. There are some people who are so much improved that they take so much extra precaution that they will keep bathing at least 3 times in a day, and they'll keep on washing hands to an extent that the हातावरती सालं निघून जातील एवढ्या वेळा हात धुतात असे पण लोक आहेत. So there are different kinds of people. But there are people who are on the borderline, those who are on the verge, those who are little confused whether to go on that side or to this side. If we continuously keep on giving these correct messages, and especially if it comes from a doctor, then they will definitely trust that what doctor is saying must be right. Or at least when they will, unfortunately, if they have to suffer after 2 months, they will say that this doctor had already cautioned us. In the month of February, I had made one video for one of our senior citizens association. They wanted me to talk on COVID. It's a small video of some 2 to 3 minutes only I have spoken there. But in that was a time in February, our cases had significantly gone down. But I had specifically mentioned, I will send that video to you and you may circulate if you wish. I have specifically said that if we don't follow this precaution, bimari fir se phailegi. These are the words I have used. It is there on YouTube, this video in my channel. And that those words I had used, and that is what exactly happened, unfortunately. So similarly, if we start don't take precautions, the third wave will surely come. Maybe because of vaccination, it will come in a milder form. We just pray to God that vaccination will save us this time. That is, at the time of second wave, the vaccination was not there to that extent. But third wave, with this kind of 5-star hotels becoming full and marriages started again. But at least don't have a doctor's conference in the 5-star hotel. That much my request.
No, we have not started offline conferences or CME still now, sir.
But for next 6 months, we should not do for sure. That kind of a pledge we should have give to each other. We will not do it for next 6 months at least. Then
we have some questions. Can I read all the questions?
Please.
5 questions we have.
Yeah.
Pyroxicam has also been used by some doctors for patients with severe COVID, and they have been drastic improvement in the patient's SpO2. How is this medication helpful? Next,
shall I answer? Because
yes, sir.
So this pyroxicam again is a non-steroidal anti-inflammatory like indomethacin only. See, the anti-inflammatories will have some role because after all, it is just inflammation which is creating problem. It is the body's wrong reaction to the virus which actually kills us. So it is the virus comes, virus just spreads, and we react to the virus to such an extent that we ourselves kill our own body. So all these anti-inflammatory, may it be steroid, may it be tocilizumab, may it be pyroxicam, may it be indomethacin, they're all working on the same line, and on the maybe the doctors have got that kind of experience, but it is not a drug which is to be used in the mainstay, because all non-steroidal anti-inflammatory can be harmful to the kidney also. When we are treating a patient who's a case of has reached to a state of multi-organ failure, and at that stage maybe kidney is already affected, and then we start using pyroxicam, the kidney may again fail further. So I would not recommend usage of pyroxicam.
So we are missing one drug. It's produced by Zydus Cadila called Virafin. It's a single dose drug with emergency patients. What do you have to say with that?
Virafin is again, I have not used that. Is it again a monoclonal antibody? Maybe there are different brand names which may be there.
With Zydus Cadila has produced, and many doctors have started using in Goa.
Okay.
And
yeah, Virafin. It is pegylated interferon. Yeah. So pegylated interferon is a drug which can be used. Again, it is expensive drug. It is not a very economical.
It's a single dose, comes in 11,000 rupees shot.
It can be used as an additional add-on therapy. It can be used. Yeah. It is like this. All other. It has an antiviral action, so it has a role to play.
And many consultants I have heard that this drug should have come 1 month before, and you would have saved a lot of. So they are very happy with this drug.
It has not still formed a part of the standard recommendation protocol, so it is not there. But it is obviously mentioned in the literature. I have not used for my patient as such to that extent. But obviously on a OPD basis, we don't use it. But for hospitalized patient, it can be. Hospitalized patient. Voice.
Question, Question on the mask. Can N95 mask be washed, cleansed with sanitizer? Does autoclaving destroy COVID virus?
No, don't do anything to N95 mask. Keep it as it is. Just keep it in that paper bag, because any such kind of treatments on that, or even exposing it to sunlight, can actually damage the protective layers which are there in N95 mask. So no autoclaving, no cleaning, no washing of anything.
No autoclaving, no cleaning. Does steam help? There is a question. Does steam help?
Steam for oneself may have some role, but I feel it is sometimes more irritating to the nasal mucosa, and those who have been regularly doing the steaming have followed doing like a ritual, but I have not done even once, and personally it doesn't appeal to me, the logic that it will just kill the viruses which are there inside the nasal mucosa. That doesn't happen. So if you don't wear mask properly and then you want to do the steaming after that, that is not right. It is best to use the mask properly and then safeguard oneself. And it is a waste of energy also, that much of heat that we are using every now and then. I don't recommend it.
Fine, sir.
All those 5 questions which you wanted to ask are done.
I'll read, sir. What is the logic behind increasing gap between the doses of COVID vaccine? More so since a single dose is not protective.
So the only logic was to actually help more people get the vaccine. Though there are some studies which have shown that it does improve the immunity to a little better some extent. But I think it was more of a rationing that the government did for it to reach the wider population, because we did not have enough vaccine production going on. So that's why it was, even after the even after suffering from COVID also, now it has been said that you take after 3 months. But that is again with the same logic that because you have suffered from COVID, there are antibodies within the person. So he will be able to manage to fight the second onslaught better. So instead, he taking the vaccine, let the other person who has not taken vaccine get it. But if it is available in plenty, the person who has suffered from COVID also can take the vaccine as soon as he comes out of the isolation. So it can be taken after even 10-15 days also.
Okay. Sir, not much is revealed about COVID due to vaccination. Is there any study or what is your opinion, experience about this? COVID due to vaccination.
COVID due to vaccination is not a reality, but only thing is that people can get the reaction to the vaccine much more. So that is there in literature, that people who have already suffered from severe COVID, if they and have gone through a stage of cytokine storm, that person, if he or she takes the vaccine, can get a bad reaction to that, which will almost look like COVID. So it is not that he has got the active virus inside him, but the symptoms may almost become like COVID, because after all, as I said, the second part of the COVID is the body's reaction which is causing the disease. That is a cytokine storm. The first part is the virus, but वो बाद में जो story चालू होती है, that story is our own body which is damaging. So that can happen to such people if they take vaccine.
Vaccine for children, Pfizer versus Covaxin, your opinion?
Whichever is finally approved, I would say just go ahead. This question people have asked umpteen number of times, even Covishield versus Covaxin. I said beggars cannot be choosers. जो मिल रहा है वो ले लो और just protect yourself. Don't go into this nitty-gritties कि इसमें ये होता है उसमें होता है. Whichever you are getting, just when you have all of them available, then maybe the mRNA based virus vaccines are better. So if that way, if it is available, we can take that brand. But till the time it is not very freely, easily available, I think whichever government finally approves, and finally government also takes decision based on the availability and their ability to produce. So all the decision may not be 100% scientific, but it may be overall advice. So we just have to follow what government says.
No more questions, sir.
No more questions. Let me just see. Although vitamins we did not speak about. Actually, we have been all taking vitamins in this. No good study which has finally concluded that vitamins do help. But then if we have to give something, we have been all using vitamin C and even the zinc also we have all used in plenty. But I wouldn't say that's something which has got a very good, strong backing from the literature. So that we have to remember. Isolation is one thing which we did not talk. So we have to educate our patients to isolate properly themselves at home. So once they have symptoms, we should strongly tell them not to get out of the house. That message has to go from the doctor, and that message can go only when we say that even mere clinic mein bhi mat aao. I can consult you on phone. You have to pay me whatever format that you ask for, maybe Google Pay, Paytm, bank transfer, whatever. But I think this has to be a strict format that, and if it goes from bodies like IMA and General Practitioner Association, it will be done. And if it was possible in the first wave, if you can prepare yourself now itself, maybe in case, God forbid, we don't get, but if the wave comes, you can follow it accordingly. In hospital,
a few questions.
Please ask.
Any autoclaving disinfect PPEs from COVID? Can autoclaving disinfect PPEs from
I don't
COVID?
know actually. I'm not aware. People might have tried, but I'm not very sure what happens to that material, especially.
Okay.
But if you are, PPE also, we have to decide when to use. It's not that you have to just sit in the clinic with PPE all the time. Like in my own consulting room, I have not worn PPE. I have not even worn gloves. I have used only N95 mask all the time. And N95 mask is the only thing that I have used with proper thing, and intermittent hand sanitization with our alcohol-based sanitizers. And one thing I have followed, that not to touch the face and the mask with your bare hand. So if you can follow that practice as a rule, then again our own getting infected, that possibility significantly goes down. So every now and then, if we start wearing PPE, it also becomes very, very uncomfortable. So that way we can avoid that.
Day one treatment question, please.
Day one treatment, depending on symptom. If it is only report is positive, we can ask them to just wait and watch and don't just remain in the house in isolation. That for sure one has to follow. And the family members also have to wear mask and all that. That person has to follow. Watch for symptoms, temperature monitoring, pulse monitoring, oxygen saturation monitoring, and reporting back to the doctor. If there are just the beginning of any viral-like symptoms, if you have to give, I may use favipiravir because I have used it, though the literature is still not talking so much in favor of that. Or I may give only ivermectin, and just paracetamol, symptomatic, again paracetamol just for the body ache and all. And just wait and watch and see how patient further develops. For all you know, only thing we have to caution them on the day one that this whole process is going to last for about 12 to 15 days. Your quarantine phase has to be followed properly. Like what the government had said, that we have to, at least for initial 7 days, you have to be within that single room only. And if you cannot remain in the single room, you have to go to the COVID care center so that you go away from the family. Especially if it is a multi-generation family, which that is our joint families, where elderlies are also there who are likely to get infected. And if you don't have enough space to get isolated, go to COVID care center and get isolated there. Otherwise, just remain in single room. So 7 days in single room. Beyond that, for 10 more days, not to get out of the house. Then you remain inside the house only. The house outside the house can be done only for the sake of doing CT scan. That too is a test which is not so much compulsory. Blood collection obviously can be done at home. So there are pathology labs who send technicians home and who come in PPE and collect the kits. So if we don't get out of the house when we are having flu-like symptoms, that is the best way we can protect our society. That much we owe to the society. We can't allow the virus to spread just even when the virus, we know that you are positive. So positive people, after knowing, they are going to doctor's clinic. I know there are doctors who are calling them morning and evening for giving some saline. All kinds of things have happened, and that is where I think doctors have done it wrong. I mean, this is not right. This is not done. You cannot call a known positive patient to your clinic twice a day for giving some saline and some medicine. ये नहीं चलता है.
So this doesn't happen in Goa.
I know Goa is a much, but these are the stories. These are the stories that I've heard.
Yes, maybe in other states. Yes.
Other states, yeah.
So there's some more questions. Is there a link between zinc and mucormycosis?
There is something which has come that this excessive zinc also can allow the fungi to grow more. There is some literature which has come. So that's why I said, let's not use any of these drugs excessively. Earlier, people were taking, every day they were taking zinc. So even I reduced my zinc intake. I now take once in a while, maybe once in a week or just once in 10 days, that way. So, or just take a very common pill, like say for example, Supradine kind of a pill, which has all vitamins and minerals together and everything in a relatively micro quantity. So rather than sort of over bombarding, and no study has yet shown that zinc is 100% protective for COVID or anything. So let's not go too much after it.
So there are cases after taking both doses of Covaxin, antibodies are 0 developed in body. What should be done?
They are to be treated as the case is, because this is unfortunate. But there are some people who may not really develop antibody. That is a fact. It can happen to some people. So that's where, though, if I have to again reiterate on this point, number one is COVID appropriate behavior. Number two is vaccination. I think we are misinterpreting. We are feeling number one is vaccination, and once we have taken the vaccination, then we have got the passport to do anything now, or rather the permission to do anything. So that cannot be done. If that happens, then again we are going to develop problem. So these are the cases, they have to be treated like vaccine. I mean, they have to be treated as COVID. But we hope that these cases will be milder, because that is what the vaccine promised. Vaccine never promised that the infection will not occur. Vaccine has only promised that the severe infection will not occur. So as we know that COVID, 80% of the people are asymptomatic or only mildly symptomatic. Beyond that, about 15% are moderate range, and only 5% become severe, and out of them, some only 1% finally die. Why? Though the percentage is this way, because the attack rate is so much, the secondary attack rate is so much, the large population gets affected at one time, that even 1% becomes a big number. That is the whole problem with COVID. So that the spread of the virus is like a wildfire. So that is what creates the whole issue, and it is a big problem. So vaccination, we have seen until number of times we have seen that in spite of taking the influenza vaccine, we can develop influenza. I would strongly urge that people should start taking even influenza vaccine. Now we have got into habit of taking vaccination. The adult vaccination were not existing on this part of the globe, at least in India we were not. But now we know that vaccination is important. So we should start vaccinating our patients also, especially those with comorbidities like diabetes, heart disease, kidney disease, liver disease, chest problems, COPD, asthma, or even pulmonary hypertension. All of them should take flu vaccine also, as well as take the pneumococcal vaccine. So please encourage your patients to take pneumococcal vaccine, which comes in two types. That is, one is Prevenar 13 and other is the Pneumovax 23. So both the vaccine at a gap of 1 year we should take, and especially those above the age of 65 should definitely take the pneumococcal vaccine and the flu vaccine for sure. And it has been shown in studies, especially studies from Brazil and all, that people who have taken flu vaccine had less number of COVID in them. The cases were less in them. So that again, and if we start using this vaccine on a bigger scale, maybe the rates will come down. Right now, the prices are slightly prohibitive. Like Prevenar 13 costs around 3,800 rupees. But Pneumovax costs around something like 1,200 rupees. But if more and more people are taking, and the companies really find that it is getting used on a larger scale, the prices may come down. So we should take it up. As association, I would urge IMA, GPA that we can take this adult vaccination program on a serious note and continue this exercise. And along with that, promote the good health practices. Good health practices like, and send these messages, especially sleep on time. Like Goa, this nightlife goes on for late time. People are partying and there are wrong things happening. So we should try to see that more and more people follow the correct practice. As we said, there are some people will never improve, but those on
Sir,
the
but Goans, the best thing of Goans who are original Goans, they have a habit of sleeping in the afternoon, or nap in the afternoon. That increases their longevity.
Absolutely. Sushegat, na kya bolte?
Sushegat is slow life.
Slow life, yeah. We all want to be like Goans. In fact, that's why I was telling my even family members, we keep always discussing, oh, the Goa, the numbers are not increasing only, just that. So I said their lifestyle is so good, that's why it has not spread in them. That's we used to discuss. Unfortunately, the second wave did hit, but I'm sure yours is a much healthier state than what we are living in. So,
sir, there is one question: cardiac events after suffering from COVID and after COVID vaccination, your experiences?
After vaccination, absolutely no cardiac. Don't go up. That's again a big myth which has gone on of causing thrombosis. That's why wherever I wrote, wherever I said, take vaccination without any doubt in mind. Because people who needed the vaccine most did not take the vaccine. That was the worst thing that happened. People who are already having cardiac disease, people who are already having a stroke, people who are already suffering from diabetes, these are the ones who need the vaccination the most. And these were the people carried the doubt in the mind and they did not take the vaccine. Still today I get phone calls from my patient that Doctor, me vaccine आम्हाला घ्यायचं घेऊ का? म्हटलं आजपर्यंत काय करत असतो? अजून का नाही घेतलं वॅक्सिन? आत्ताच्या आता जाऊन घे म्हणा. So there is nothing, we just cannot, no problem after vaccine, any thrombosis. COVID-related cardiac events definitely have occurred. There is no doubt about that. COVID does cause the hypercoagulable state. So it can cause myocardial infarction, it can cause pulmonary embolism, it can cause even DVTs, even skin problems have occurred. There's something called a COVID toe which has happened. There's a gangrene of a toe which was called as COVID toe, which came up as a only symptom of COVID. So all these things have occurred. So it is possible. It can happen. But then we have no option. And that's the time where the use of low molecular weight heparin, and if required, the newer anticoagulants like apixaban or the rivaroxaban, it comes in picture. Like such cases, we even continued sometimes the newer anticoagulants up to 2 months or 3 months also, where the patient went through a bad COVID, and then there was some documented hypercoagulable event that happened, where we continued these anticoagulants for a longer period of time.
Sir, question is, favipiravir to be given for 7 days or 14 days?
7 days is enough. It is 7 to 14 days, it was the recommendation. But I think if we are starting early in time, even 7 days is all right. 7 to 10 days is what I have used. I have not given to any patient up to 14 days, but up to 10 days I have used. And now I have started writing 7 days only after seeing that it is not giving that great result. So why make the patient pay more and spend more money?
So does the LFT rises in favipiravir?
Yeah, LFT, even uric acid can sometimes go up with favipiravir. Sometimes even we can get low WBC count also. Little leukopenia also can happen. Leukopenia anyway can happen with even COVID, but it can happen with this. That leukopenia and this lymphopenia we did not talk much about. These are the indicators of severe COVID. That the ratio of neutrophil to lymphocyte ratio also played a role in identifying the severe COVID. And even CRP value going beyond 75 has been considered to be a part of severe COVID, where there is a role of tocilizumab that came in picture with that. So these are a few points that.
So there's one more very interesting question.
Yeah.
Does evidence-based medicine, Coronil, work? Also, homemade Kara's turmeric milk work?
No trials done. So all these are. So finally, as if we talk of evidence-based medicine, it is very difficult to say whether it works or otherwise. There are drugs like methylene blue also, which people have used. There are other some homeopathic drops also, like arsenic drops, people have used as a preventive. So multiple things have happened. Unfortunately, in our country, the culture or the system is not such that we can easily go into the standard format of doing a trial. So these things do not come out as a proper paper. So we keep using out of experience, and there may be a good potential, but we are actually missing on the potential just because we are not conducting good trials. So that is where I think India has really lagged behind. Because having so many cases and having access to so many medicine, because in countries like USA and all, we don't get easy access to medicine. Here relatively the access to medicines is more, but our data maintenance, and if it was good and if we could analyze the data, we could have really guided the world how to treat COVID. But unfortunately, we are still getting guided by the Western world, and we are following their footsteps in what is to be followed.
When to start remdesivir?
Remdesivir again is a drug which should be started as early as possible, but especially only in severe cases. So that is the real catch in that. So you don't give remdesivir to just because your report is positive. But if it is started too late, again it doesn't make sense. So it should be given in hospitalized patient for sure. So patients who are developing hypoxia, and if that is within the first 9 to 10 days, we should definitely give them remdesivir. So any hypoxia, but not even requiring oxygen. See, because the therapy of oxygen also we are using judiciously. We don't want to. So what are the targets for achieving oxygenation is that we have to maintain, in the initial stage, we want to keep oxygen level above 94, and in maintenance stage, we want to keep oxygen level above 90. So for example, a patient is admitted to hospital because he was feeling breathless or he was having some weakness, but his oxygen level has not really gone below 94. Say it is just, or it has just touched 93, but it has not gone below 90. So such patient can still be a candidate for remdesivir. Here we don't have to wait for the oxygen level to drop below 90. But tocilizumab is not given for these patients without requiring oxygen. And for that matter, the recommendation for dexamethasone also is for those patients who are only requiring oxygen, not for otherwise.
Sir, in patients where nothing is helping and patient is getting worse, like tocilizumab is given, remdesivir is given, in that cases, I have seen that remdesivir, they just go on continuing, whether that helps.
It doesn't help. See, the normal recommended course is only up to 5 days. But the literature has said if the patient is on mechanical ventilation or if he is on ECMO, that is external extracorporeal oxygen, then we can go up to 10 days.
Sir, as you have said ECMO, have you seen any patient coming out of ECMO?
I have not really managed very, very critical patients because our hospital where I'm attached did not have initially the policy was not to have COVID in the ICUs and all that. So I wouldn't say that I have a big experience of ECMO as such.
No, at least have you heard any one patient?
Yeah, there are patients who have recovered. There are patients who have been on ECMO and they have even undergone lung transplantation also and have survived. So patient on ECMO then gets actually airlifted and they go to certain centers where the lung transplant is done and patient have come out of that. It is not so it is impossible. These are rare cases, but possible, definitely possible.
Okay. What are the recommendations for influenza and H1N1 vaccine? What are the brands available?
Recommendation is that actually if we see the textbook of Harrison, it is said that every individual above the age of 6 months should take influenza vaccine every year. That is a recommendation. So all of us should be taking, even the children should be taking the influenza vaccine. It is in 2 strengths that is come. For children below the age of 5, it is 0.25 ml, and for adults, it is 0.5 ml that we take. The brand which is easily available right now is Influvax, but there are brands like Vaxigrip or Fluquadri or Influvac Tetra, because it is either it is trivalent or quadrivalent. So if it is quadrivalent, then it comes with that Fluquadri or that Influvac Tetra. So these brands are available. The price is slightly different. For trivalent is around generally 800-900 rupees. And if it is quadrivalent, it is around 1300-1400 rupees, that range. So it is recommended. And those who are elderly or those who are really having a lot of comorbidities, it can be given every 6 months also. Though it is recommended every 6 year, every 1 year, but it is recommended, it can be given every 6 months also. So that is the advice for that. And Prevenar 13, which is for pneumococcal, is to be given only once in lifetime, whereas Pneumovax 23, which is to be given every 5 years. But above the age of 65, we can stop giving that every 5 years. You can give only once also. Pneumovax 23.
Sir, some words on Delta virus.
Delta virus, it is actually just a variant. It is just, these are variants of concern. Basically what happens, the virus continues to copy itself. And while copying itself, the virus does some mistakes. So that mistakes, when they happen, some of the mistakes are for the good of the virus and they start surviving better. And these are the viruses, they can actually propagate faster. So they may have a faster rate of transmission. They can sometimes evade the vaccines also. Like for example, this Delta variant, like even the first antibody cocktail which was there starting from that B, it is not working on this Delta virus. So that's how even America, they have stopped using that first cocktail. and now the new cocktail, which is with C and I, has come in picture. But we don't have to really get worried about it. The therapy remains the same. The protection, the way, whatever preventive measures we have to follow are the same. And the vaccines which we have taken, like the AstraZeneca vaccine, that Covishield, or even Covaxin, both of them are effective against Delta virus. So we don't have to really worry that we have taken something inferior and we are not going to get protected. So that's a good news. Definitely, that vaccines are working. And I think vaccines are working right now. As I'm telling you that we are seeing less of COVID but more of flu. That means it is probably the protection is we have got for the vaccines only. So just
why foreigners in other countries they call Delta virus an Indian virus?
because it was first reported from India. In fact,
That's
we should be proud about that. That our lab, yeah. See, because unless we do the genomic study, we will not be able to know the variation. So it is good that our country is advanced enough now that we are doing genomic study of our patients, and because the genomic study we could report that variation. The other viruses, that alpha, beta, gamma, and epsilon, they have also they must be there also everywhere. But those countries particularly reported, like something was reported from South Africa, and then something was reported from this United Kingdom. One was reported from USA. So that's how it is. It was reported from there, but it was, I don't know whether it really evolved there. And why the second wave came, I don't believe it was because of Delta variant per se. It came only because of our inappropriate behavior. And the inappropriate behavior had started from October 2020 onwards only, till the time it went into that exponential graph, and till the time the actual effect was seen, it took about 4 or 5 months. So if we start our inappropriate behavior now, the effect of that will be seen maybe in January or February. So it will still come. So we have to still follow the COVID appropriate behavior for at least 6 more months. It is expected by the people who are expert epidemiologists that by mid of 2022, the virus all over the globe will significantly go down. That is the expectation. I have heard from one Dr. Ravi, who is from NIMHANS. He's a very senior doctor. In his talk, I have heard that he anticipates that somewhere around mid of 2022, the virus will go away, and maybe the recommendation for wearing mask also will go away by that time. But till that time, we have to maintain our patience. If we lose our patience and if we start intermingling with everybody, then I think God.
So which year did you say?
2022. That is next year. आता आपण we are in 2021. पुढच्या वर्षीच्या मध्यापर्यंत, if we all follow the proper COVID appropriate behavior, the virus should die down.
But WHO असं म्हणते की 5 वर्ष आपल्याला कोविड खेळायचंय.
बरोबर आहे, खेळायचं आहेच कोविड 5 वर्ष. ते खेळायचे कारण आपण ह्या चुका करणार आहोत हे त्याच्यात एक गृहीत धरलेलं आहे. बेसिकली ही थर्ड वेव्हचं सुद्धा, द वे दे कॅल्क्युलेट थर्ड वेव्ह is expected that when the lockdown is opened up, what will happen? Because lockdown opening is a compulsion. See, if we follow the lockdown the same way we followed till now, the COVID will not come, because it has been now confirmed beyond doubt that if we follow lockdown, the COVID goes away. But we cannot live in lockdown. That is the problem. We have to mix with people. We have to meet friends. We have to have partying. People invite people to others to their residences. That is the most dangerous thing. See, going to gardens, going to parks, jogging in an open place, even playing in open place, I feel is safe. Please mark my words. These are my strong opinions which I am trying to put forward on this platform. That is, open places are safe because the virus will spread away. And people who are healthy will definitely come to the open places to exercise and all. But when people go to somebody, Saturday ko aake, we will meet at your place and we will have party together. We will have food together. We will watch a movie together. All these kind of things people do, and they suffer. I have had live examples like this from my patient describing this story, that XYZ person gets symptoms on Tuesday, And last just 2 days ago on Sunday, we had invited our 5 friends at my place, and then we all sat together and we ate. And then on Saturday, I started having sneezing, and on the Friday, my smell disappeared and my test went away, and that's why I'm calling you. These are the typical phone calls that you get, and then you feel, why did you invite your friends on your way? What is the hurry? You can always do these things. I even feel the marriages and all can be done on online platforms. If you want to get married, now get married. The marriage should not be stopped. But even allowing 50 people or 100 people for marriage is so dangerous because we don't follow, we find tricks. For 100 people are allowed, that means in the first 1 hour, 100 are allowed, second 1 hour, 100 are allowed, in third 1 hour, 100 are allowed. So that way 300 people come and the first 100 don't leave. The first 100 stay there, uske baad mein 100 more come, then 100 more come. Then it's a big crowd of 300 which is there, and all of us eating together. They have removed their mask. There's some Sangeet program going on. People are singing songs in the stage, and this is what happening. This exactly was happening in month of February this year. I have attended one such marriage, so I can tell you from my own experience that what people were doing in February.
Very recently, I was talking to a marketing guy of a 5-star hotel, and I asked him how many people are allowed. He said, "Government ने तो 50-100 दिया है sir, और हम manage कर लेते 200-300." This is happening. It's not 100%. It's not possible to
manage करने का जो attitude है ना, that manage करने का attitude has actually created the whole problem. And I think that is where probably China has scored over us because of their strict administration. This kind of manage attitude has not been sort of tolerated or permitted there. And that's why I have been keep wondering from the day one, they have been reporting only 4,800 deaths. If you see that COVID visualizer, which gives you the data at one point, or there are other sites also, China is reporting deaths only below 5,000. People are saying that they are all faking, they are giving wrong information, but I don't believe so. There must be truth because there are Indians who are staying in China, and I have talked to a few of them, and they said, no, we don't have COVID there. There is no COVID there. So it is only because of their correct COVID appropriate behavior that they could actually manage to control this.
So we are absolutely enjoying your talk, and you are giving us absolutely a very good answers which we really want. And I think we might just continue this for another 2-3 hours, you know. But now it is 7:20. What I will do is there are a couple of questions there. I'll just read it together, and then if you can just fastly, if you can just touch those questions, we'll be really grateful, sir.
Definitely.
What are the cutoff numbers for investigations that point towards severity of COVID requiring admissions? The next question will be, how long the immunity of vaccine will last? Any booster dose of COVID vaccine recommended? So this is a question where everybody asks and they have in their mind. Then, is there any role of antiplatelet? The next question, does antibodies formed in COVID recovered patients fade over time? What about antibodies formed by vaccine?
Yeah, good. So I'll take that vaccine antibody question first. Saying that is most important. And the antibodies will fade. They will not last long. And I have a feeling that that if these kind of variants keep happening, and if there is some variant which is evading the vaccine also, it will be like how for influenza there is a recommendation to take vaccine every year. Similarly, I think COVID vaccination also may become a yearly business later on, or both these vaccines may get merged also together. If that happens, it is good. That flu vaccine and COVID vaccine may just come together. So that may happen. So the booster dose, as far as the literature is concerned, and what I have just confirmed today from uptodate.com, as I am referring to that website repeatedly. One good thing I want to tell you, uptodate.com is a paid website. Uptodate.com is a paid website, but the COVID-related, all the literature, COVID-related literature of uptodate.com is free. So you can always access those material without subscribing to uptodate.com. For other literature, you have to subscribe to that site. So that is one important thing. So there what has been mentioned is that people with poor immunity, poor immune status, those who are immunocompromised, those who are maybe HIV patient with low CD4 count, cancer patient, all that, there the role of booster vaccination has been recommended. So we can recommend the third dose, but I don't know whether Government of India is still actually permitted. So as far as our dosing is concerned, whether it will be allowed if we go to a vaccination center and we ask for a third dose, whether we will be actually given that kind of a dose, I am not sure about that. So that's why. So, but the antibody levels are going to go down. What we will be dependent on is the T cell immunity also, that is cell-mediated immunity. And there is no good way of measuring the cell-mediated immunity. So that's why one may show low antibody, but still may be able to protect from COVID, because when we get exposed to COVID, our T cells will recognize and then the antibody production will start. So it all depends on how soon the antibody production starts in our body and how soon we are able to clear the virus. If that happens fast, then we will still be able to clear the virus even when our antibody levels are showing low. One important point I want to add here is that which antibody you are testing is also important. If you check antibody for spike protein, these are the antibodies which are produced by the vaccine. And if you check the total antibodies, you may still get low antibodies after even getting vaccinated.
So which antibody has to be tested, sir?
Ideally, no antibody should be tested. I have not tested my antibody level. Don't test antibody. It is recommended in the literature also that don't do antibodies. It's a waste of test, unnecessary needle prick, and it gives you false security, and you try to break that COVID appropriate behavior because of that. So don't do that. But if you have to really check as a scientific answer, and after vaccination, and if you have not suffered from COVID at all, and if you want to do only see the effect of vaccine, it is the spike protein antibody that is to be checked. So that was the question to that. With the answer to this question, I think there was one or two more questions which were asked. One more.
Sir, I'll just read. Yeah, does antibody, okay. What is the ideal anticoagulant to be used orally and how long?
Antiplatelet was also one question. No antiplatelet actually recommended.
Is there any role of antiplatelet?
And no role. Anticoagulant, I think I already mentioned that. And there was one question about these cutoffs were being asked for the blood test. So blood test cutoffs, there are no good cutoffs. Go more by the clinical. So these biomarkers at one point were thought as maybe a very useful tool to pick up the complicated cases. But then it has been shown that don't go by the biomarker. But still, you can get a trend. Say if you have done a CRP level today, and if you are repeating the CRP after 3 days, and if today's report is showing a reading of say 5, which normally should be below 6 or even much lower than, but that 5 becomes 20 after 3 days, and the 20 becomes 40 after 2 more days. That means the CRP is showing a rising trend. So it can be taken as one of the indicators to pick up that the patient is worsening, or if the lymphocyte number is dropping further, that can be taken as an indicator of worsening, or even SGOT-PT level is rising, that can be taken as an indicator of worsening. So these are just indicators, but go more by the patient's history, whether they are able to walk in the house properly. We did not speak anything about the 6-minute walk test. Actually, 6-minute walk test is an important tool to pick up early desaturation. So if there is a desaturation happening after walk test, if it is dropping below 95, or from your baseline, if you get a 3% drop, say for example, somebody is 99, and after walk of 6 minutes, if the saturation dropping to 96, that can be taken as a significant thing. One just important point, those who are having a relatively higher carbon monoxide in the body, those who are smokers tend to have carbon monoxide in the body, they may show falsely high reading on the pulse oximeter. Or those who are having very dark skin, especially it is the blacks from the Africans from the USA, may show falsely high readings. And those who are anemics can also show falsely high readings. So SpO2, that is the saturation that we pick up, is a surrogate marker. The best way to know the oxygenation is to do an arterial blood gas. There we can pick up the partial pressure of oxygen, and that is how we can document the hypoxia.
Sir, I request all the members, we will stop giving questions. There are only two more questions. I will like to read it. What is
Please.
the gap after COVID vaccine to take the flu or pneumococcal vaccine?
Yeah.
Next question. Was second wave primarily constituted by the Delta variant?
No.
Next question. One more last question. Sir.
Yeah,
Could we say that herd immunity is starting to develop?
So first, that vaccination question. Ideally, when we take vaccines, what the dictum says is that all vaccines should be taken on the same day. In fact, the pediatricians follow this, and that there is a scientific logic also behind that. That these vaccinations, when the whole process of immunity development starts, if it starts together, there is no clash in between. So that's why if you have not done that, then ideally we should leave a gap of at least 3 months between the vaccine. So if you have taken a second dose now, but if your second dose is still due, then you can take COVID vaccine and the flu vaccine on the same day, on the two different arms. So that can be done. Like even for the pneumococcal vaccine and flu vaccine, if I am giving for my patient, I tell them to take both on the same day on two different arms. That is the thing. Now, as far as the wave, whether it is if it is a good herd immunity that is giving it, only the time will tell us. So it is appearing to me that because the flu is spreading but COVID is not there, maybe we are developing some better herd immunity, and vaccination has played some role in that result. But it's appearing to me, but it is too early to say anything. So we have to continue following the COVID appropriate behavior. And what third was, I think, something on the same lines. I think I had already answered that question. Yeah.
Yes, sir. You have answered it. Yes, sir.
Hmm?
Yes, sir. Thank you very much, sir. And
What is mixing of COVID vaccine? Somebody, I just saw that on the flashing there. So mixing of COVID vaccine also is a good question, because
what is mixing of COVID vaccine? Yeah.
Where we use one. See, we were strictly told that if you have taken Covishield, take Covishield only as a follow-up, or if you have taken Covaxin, take only Covaxin the follow-up. But in the out of experience, it was seen that because of the non-availability, sometimes people took different vaccines also, and then when they were studied, it was seen that they developed good immunity. Actually, it is out of logic, because all vaccines, when they are acting by on different mechanisms, if they are acting by different sites or different mechanisms, then by giving two different mechanisms, in fact, it may give better protection, and that is what is actually seen. So mixing of vaccine, if it becomes a trend, it will be good trend, so that then we don't have to wait for actually availability of one single vaccine. So whichever is available, we can keep taking those vaccines also.
Post-COVID pulmonary fibrosis and use of NIBs.
I have mentioned about that. Yeah, it is either pirfenidone or nintedanib we can use. They are useful, but the case should be properly chosen. We should not just keep using for everyone. Those who are having definite fibrosis on a CT scan, there is a role. We need not keep doing too many CT. There is again excessive usage of doing CT also, that should be also avoided. Just as a follow-up CT and all that, follow-up CT and just to see the score. Abhi mera score itna tha, abhi itna ho gaya. That for the sake of doing that, we should not keep repeating CTs and exposing ourselves to radiation. So go more clinical. Finally, the message of COVID management is that we have to go more clinical, and the basics are finally going to help us. In fact, what was being followed in 1918 when the Spanish flu came, the same thing is being followed now also after 100 years. That is mask wearing of, I think there were nice pictures which are going on WhatsApp, which had shown that in fact people that time also had followed the same precautions of keeping the distance and wearing the mask and all that. And even after 100 years, that old has proven to be the gold. So and all the new drugs are still.
So the question is saying patients PFTs in COVID and post-COVID useful? Question mark.
Yeah, PFT will be useful to document the improvement, obviously, or the document the severity.
Even in post-COVID.
Post-COVID, yes, yes. It is
Sir,
useful.
as a general practitioners, we are very grateful. Give us a home message, home taking message, what you want to give us as a, for general practitioners.
General practitioner, first and foremost, be happy, enjoy life. I think you are one of the examples of happiness, I feel, the way I can see your face. So,
Thank you, sir.
and live like a caveman. That is my one line message.
Okay.
Live that may require one more lecture, but
No,
I may just
not like a king.
not like a king. No, no,
Not
don't
like
live
a king. No,
live
no.
like a caveman. All
Caveman.
your inner desires and whatever your basic instincts are, you go by the basic instincts. You eat food which is to be also eaten like a thrifty person. Caveman was not getting so much food as we get now. Caveman had to struggle to get food every day. Caveman could not remain awake at 1 o'clock, 2 o'clock watching movies and watching cricket match and football match. Caveman had to sleep after the sun had set. So these are the things the caveman was doing. He was living in a limited, small world. He was not aware of what America is and what America is doing and what is happening in Afghanistan. Also, caveman did not know. So he was living in his own small world, and he was happy with his wives and childrens, whatever were there around him. So he was enjoying his life. So one line message is live like a caveman.
Sir, we had more than 380 participants.
Wow.
Congratulations. And I hope all our members have really enjoyed and taken very good message from Dr. Pushkar. Dr. Pushkar has advised us to go to uptodate.com COVID section. Right, sir?
Yeah, you go to uptodate.com and
yeah.
COVID related material is free.
COVID.
So you can read COVID related material without paying any.
So I request members to be in touch with uptodate.com. So whatever recent latest things will be
So if they have to
updated there.
say now COVID-19 outpatient management, this is the section where most of the material that I spoke, I have picked up from there. Because I wanted to give you the most authentic and the latest information. So purposely I did that exercise since today morning and again confirmed that whatever I am going to tell you is the latest information, and this may keep changing. So after maybe 1 month, there will be some new thing which will come there. So keep following that.
The other important thing is to take ivermectin. Sir has advised us every 15 days or every month, one single dose, sir, right?
12 milligram, yeah, 12 milligram.
12 milligram. Anything else you want to say,
And
sir?
COVID appropriate behavior.
COVID appropriate behavior.
So माझा मेसेज प्लीज पाठवा सगळ्यांना. मी तुम्हाला
हो
परत पाठवतो.
हो आपल्याला पाठवून द्या, मी पाठवतो. Thank you, sir. Thank you very much, and we are really grateful. And even first time we were very happy to see you, and again the second time was excellent. I have no words, and I think all my members do agree what I'm saying. We will have you back, sir.
Sure.
And we'll be in touch with you. Sometimes it is scary to hear all these things. What is going to happen, we don't know really, and nobody knows. It's a mystery.
True.
And life is a mystery. So we have to take it how it comes.
Yeah.
Thank you very much. And I request Dr. Paresh Kamath, Secretary, to say some words, and then Dr. Yogesh for Thanksgiving.
Thank you, Dr. Pushkar, for a very informative talk. And I also want to tell you, as we are not physically present, we will send you the certificate from our GPA as well as a small memento from us by post. You will receive it within 1 or 2 weeks.
Definitely, sir.
That was a very nice talk today.
MMC point पण पाठवून द्या.
हो.
ते आपण डिजिशील्ड वाल्यांना सांगायला लागेल का तुमच्याकडूनच येईल.
आमच्याकडनं येईल, सर.
Okay, thank you.
You are not audible, Paresh. Very good.
You can hear me now?
Yes.
Okay. Thank you for this very informative talk, Dr. Pushkar. And I just told you that I will send a memento from our side, that is GPA Vaccination of Goa. you will receive it maybe within 1 or 2 weeks. I'll get your address from Dr. Samuel. Okay. Thank you very much.
Thank you so much.
I request Dr. Yogesh Shetty to give a thanksgiving word of thanks. Dr. Yogesh is there?
Or you can
तू ही दे देना thanks.
you can just thank you.
Yeah, thanks everyone. I thank all my members to be present here by such a large quantity. And I thank DG Shield, Mr. Deepen, Mr. Piyush, who have given us this platform for sharing this CME. Yes, Dr. Yogesh has come. So let him say some words. Dr.
Yeah,
Yogesh.
I'm there. I'm listening to all the interactive talks. Hello, good evening to all of you.
Hello, hi.
Thank you, Dr. Samuel. I'm listening to all your interactive. Hello, don't go. As a COVID protection, I have just completely cheered up.
Wow.
Okay, thank you, Suyo. Thank you, Doctor. On behalf of GPA Association, I, Dr. Yogesh Shetty, Treasurer, would like to thank Dr. Pushkar for giving us a very, very, very good talk. Your talk, the interactive session was superb. You covered all the small aspects and gave us a complete clear idea about all the COVID picture. And your caveman theory, I want to really, when we meet, I want to talk about, ask you about all that caveman. Caveman is a beautiful concept. You have to next time elaborate more on caveman topic. What food to eat and how to build a defense system. And Dr. Samuel, very wonderfully, very softly, every questions you asked were very important, very interactive. And
Sir,
next
time we want to hear doctor's voice. Doctor is a good singer.
Very
Dr.
good
Pushkar is a good
singer.
singer. We remember that.
Only
Yes. We will have
what we missed was we all sitting together and post CMER interaction from our GPA colleagues also.
True.
So next time we will surely meet. And
Six-
thanks
six-
to all the GPA
6
members,
months-
though we are not
6
all
months
visible
we-
in this thing. Thank you all for attending.
Yes, sir. What you were saying?
Hello.
6 months we wait and then we meet in Goa.
Definitely, sir. Definitely.
6 months एकदम tight
Sure,
पकड़ के रखो।
sir. We meet.
Tight पकड़ के रखो।
Yes,
We
sir.
keep a social. We keep a social distancing and we just make the minimum people and we meet again. Thank you very much. And thank you to all the GPA members. And thank you
Thank
very
you,
much, sir.
members. Thank you, everyone.
Bye.
Good night.
Good night. Bye.
Good night.